into the room. And Marion, if you'd let us know when we're public. Thank you. It's us, yes? Okay, welcome members to the 34th meeting of the Public Accounts Committee in this mandate. Can I advise members that the committee meeting will be recorded and broadcast throughout Parliament buildings and online. However, there could be a slight delay in moving between any private and public sessions, so please be patient. Can I also advise that those in the public gallery are welcome to use mobile devices as long as they're in airplane mode and the devices are muted. You can connect to the Assembly Wi-Fi. The password is in the gallery rules, and it is not permitted at any time to take photographs or record any part of these proceedings. Declaration of interest. Can I ask members if there's any relevant declaration of interest to declare for this meeting? Okay. We have apologies. Members from Padraig Delargy. We have Colin Crawford joining us remotely, and you can see and hear us okay. And Colin Gildernew will be joining us shortly. So with that said, members, can I thank you all for your attendance. I'm going to take this opportunity to welcome to the meeting Darina Carville, the Comptroller and Auditor General, and her team, along with Kyle Bingham, the Assembly Support Officer for the Northern Ireland Audit Office as well. We'll refer now, members, to the draft minutes. There's a copy in your pack from the 27th of February at page 8. If members are content that they're an accurate reflection of the meeting. Okay, thank you. Okay, members, at pages 3 to 4 of the table pack is a brief in respect of the launch of the survey into access to general practice in Northern Ireland. At this point, I'm going to ask Kirsten, who has done a huge amount of work on this, to give us an update on the survey. Thank you.
Okay, members, so the majority of the information there will be in the brief, but just to give you an update, that was the figure as of yesterday when this was written. We're now just at 10,900 responses. It's a little bit frightening as I'm watching them tick up on my screen. So we did have a couple of issues raised, and I know some of the members raised those after the weekend, just around some of the questions that meant you had to indicate a negative response to progress through. Those were amended on Monday morning, and we've had no further issues with that. But the survey does seem to be gaining a lot of interest. Comms have continued to campaign to advertise it as well. And if there are any issues, just bring them through to the team. But hopefully that seems to be running well now for us.
10,000.
Yeah, there's a substantial amount of engagement in relation to this and a huge amount of interest as well. So it very clearly shows that this committee has its fingers on the pulse of a very clear issue for our public. And the level of engagement is significant. Cheryl, do you want to know?
Thank you, Chair. Yeah, I just wanted to say it's something I've never seen before, that level of interest, and I think we all knew this topic was going to be, which was going to be one of interest, but to that level it is fantastic. I just want to know, or if we can get the figures to see, as a comparator to other surveys that have been done, you know, is that something we can have a look at just to see the level of feedback, which I would say would probably be significantly higher than the law.
There's a mechanism within Citizen Space that we can see how many responses there have been to other consultations, so we can certainly do a bit of a comparator for you.
I don't think there's been as many responses to the programme for government, so it shows you the significance of this particular issue for quite a lot of people. Anyone else have anything on the...
Just to congratulate Kirsten. I mean, Chair, you know, it's actually how the actual survey is designed, and that's why it's easy access for people to do. You don't prefer, you know.
Can I just say, when are we closing that?
3 weeks.
In 3 weeks' time, so it's still available for...
It will close at midnight on the 27th of March.
Yeah. Okay.
So if we're a week in, roughly, and we have nearly 11,000 responses, this is a hot topic for a lot of people and an issue of great concern, so all eyes on it, I'm sure. And this has also been key, actually, to spark an interest in this and the work of the committee around this issue as well. So thank you to Kirsten. Just to echo what other members have said for the work that you and Lucia and the team have done in relation to that survey. Okay, members, are you content to note the action taken by the PAC team to address the issues raised by members of the public in respect of the survey?
Right.
Okay, thank you. Members, at pages 15 to 18 of the table pack are requests to engage with the committee in respect of the inquiry. Are you content to consider the requests from GPNI and the practice pharmacist at agenda item 9 when we are considering the forward work programme? All agreed, okay, thank you. Okay, members, agenda item 5 is the inquiry into access to general practice in Northern Ireland, oral evidence from the Department of Health. Pages 68 of the table pack is a letter from Peter May, the Accounting Officer, Permanent Secretary of the Department of Health, in response to the queries raised by this committee regarding salaried and locum GP costs, the Encompass system and electronic prescribing. We also received a letter from RCGP following up on evidence provided last week, and we're very grateful to our witnesses last week for spending so much time with us and taking our questions, and just to put their appreciation on the record. Okay, members, can I refer you to this, the suggested questions of pages 9 to 13 of the table pack for you to consider, and as discussed previously. At this moment, I'll ask that our witnesses are invited in. Thank you. Okay, members. Can I take this opportunity to welcome to the meeting, who will be joining us as our witnesses, the Accounting Officer of the Department of Health, Gerard Cassidy, Director of Primary Care for the Department of Health, Dr. Margaret O'Brien, of General Medical Services, Strategic Planning and Performance Group, Department of Health. And also joining us in the room is Dorina Carville, as outlined earlier, the CNAG from the Northern Ireland Audit Office, and Stuart Stevenson, Julie Sewell from the Treasury Officer of Accounts, Department of Finance. Mr. May, Mr. Cassidy and Dr. O'Brien, welcome to the Public Accounts Committee. Welcome back to the Public Accounts Committee, I should say, and thank you for agreeing to give evidence today. It is good to have you here so that we make the best use of our time, and as you'll appreciate, we do have quite a lot of burning questions. We'd ask that you would keep your opening remarks as brief as possible, because it's very likely that a lot of the questions will touch on on some of the points that you're going to be raising, and we will have significant time constraint today given the numbers of questions that I know members have following previous evidence sessions. So if at any point I interject, don't take it personally. We're just trying to move the agenda along, so I appreciate your understanding in relation to that. I would like the session today to focus on how we can best use our available resources for GP services, notwithstanding the announcement that has just been made by the Minister to expand primary care facilities and GP practices, which I'm sure you'll want to touch on as well, probably in your opening remarks. We've heard a lot about funding last week, but I want to emphasise that this inquiry extends beyond funding, and we will want to explore a number of areas with you today, including short and long-term improvements to patient access, workforce and retention issues, contractual issues, and regional disparities and equity of access of GP services, including MDTs. So with that said, and again, a very warm welcome, can I invite you, Mr. May, and your colleagues to briefly make some opening remarks. Thank you.
Thank you, Chair. Good to be back with you today, and I will keep my remarks brief. So my colleague, Gerard Cassidy, is the Department of Health's Director of Primary Care, so leads on the policy for primary care, and Dr. Margaret O'Brien, a qualified GP, is the head of our General Medical Services within the Department's Strategic Planning and Performance Group. Let me say at the start, firstly, how important an issue general practice is, how central it is to the delivery of health and social care, and how committed we are to making primary care a success. Secondly, let me welcome the report that was done by the Audit Office and signal that the recommendations, accepting that in a couple of cases we partially accepted, we are progressing the implementation of those recommendations to the timeframes that were set out. Thirdly, you invited me to say something briefly about the Minister's announcement this week of an expansion of the multidisciplinary teams in primary care. As a result of a transformation bid which was made and approved by a transformation board and then by the Northern Ireland Executive, this will see an expansion of the MDT service to 2/3 of the population of Northern Ireland from the current 1/3, and I'm happy to go into more detail in the questions you may wish to ask about MDTs. Thirdly, fourthly, I should highlight that the nature of this report can take us into the policy space very easily, and there may be some things which I believe are for ministers to respond on rather than civil servants, and I hope you'll understand if we do get to that place. I won't be looking to hide, but it's just to flag that is an inevitable potential consequence of the nature of this. And the final thing I wanted to say is we are at a very late stage of the negotiation of the GP contract for 2025-2026. And I hope, again, the committee will understand that while we can go and explain broadly the areas under discussion, we want not to get into detail about numbers because of the nature of contractual relationship discussion that we're having, which we hope will be resolved in a matter of weeks, obviously before the start of the next financial year. So those are the only comments I wish to make by way of introduction, Chair.
I appreciate you keeping your remarks brief. We have quite a number of areas, 8 or 9 different areas to touch on, which hopefully you'll be able to give us some clarification on. I'll start before I bring in other colleagues, but what is the department doing to improve patient access to GPs right now?
Okay, so thank you for that question. I think we all know that access to GP services are one of the hottest subjects, probably one of the hottest subjects for all of your mailbags. We have been taking a number of actions over a number of years to try and enhance GP access, including investing money during the COVID period, where over 90% of practices took up a total of 2.3 million to assist with telephony services for GP access. You asked specifically what we're doing right at the moment, and GP access is one of the things that is on the table for inclusion in the contract this year. We're looking at ways in which it is possible to secure guarantees around the access, for example, online access to online appointments on a more ready basis, on the basis that if we could remove the non-urgent from the queue early in the morning, then that would enable more people to be able to get through more easily. I think on access, it is also just worthwhile my highlighting that there are some practices that do this very well and where you will hear many fewer complaints about access. It is not a one-size-fits-all. And so one of the other things we're looking to do is to develop a best practice guide to encourage all practices to learn from the experience of the best. Inevitably, some, for example, small single-handed practices perhaps have less capacity than some of the bigger, larger partner practices, and that may be part of the feature here and one of the issues that we need to try and provide support and guidance, as well as trying to move ahead in terms of moving towards minimum standards. We won't be getting there this year, but we hope to at least set a bench plate this year in the contract negotiations.
Thank you very much for the answer to that question. As you'll be aware, obviously as a result of the report by the Northern Ireland Audit Office, we're having this inquiry, and it is a fairly detailed report. What specific actions have been taken in response to the concerns raised in that report since it was published?
Well, there are 8 different recommendations, Chair, and I don't know that the committee would want me to go through each one in detail. What I can say, and I'd be happy to pick up on some individual ones, but the first one, for example, was around GP activity data. So we have introduced a standardised process for GP activity data as part of the 2023-24 contract, and that focuses on the way GP practices record their appointment and non-appointment activity. And that goes beyond just what the GP or the practice nurse does, but deals with all the professional elements that are associated with the GP practice. And we see that as the first step in the process to creating a consistent approach to in-hours activity across GP practices, and it's based on the standards set in NHS Scotland. We are looking to build on that as we go forward, and specifically, I think the date for seeking to have made progress on this one is April 2025, and we are on track to deliver against that.
And of the 8 recommendations, how many of them have been implemented?
So I think that they are all got future dates for final implementation. As I said, we are on track to deliver, but I suspect none of them have been completely delivered, but many are in the process or have chunks of delivery against them, and I'm happy to provide a little summary if that's useful to the committee.
Okay. And given the concerns raised in the report, is there any way you can provide data to demonstrate whether access to GP services has actually improved since the report was published? I know you gave an example there briefly, but is there any others?
We have found it very difficult to secure the base data because when somebody phones and gets an engaged tone, it is not proven possible for us to identify how many people are in that situation. Where people are in a queuing system, we can absolutely measure that, but it's very hard to therefore measure the total, and that makes it very difficult to be able to demonstrate the improvement that you are looking for. What I do know is that we see practices introducing improvements on a regular basis, and we think that that is making some impact, but we know that there remains challenges, and we've all heard a story at least of somebody who found it difficult to get a GP appointment, and that is a concern not just to the GP but also to us in the department as well.
Thank you. Just a final question for you before I move on to the Deputy Chair, Cheryl Brownlee. What targets or key performance indicators have been set to track progress in relation to the recommendations of the report?
So the recommendations may not lend themselves always to specific targets. You'll see that there's a couple on GP workforce data and the GP workforce plan, and we're making good progress against those. We have a suite of measures we've taken around GP recruitment and retention, including a GP retainer scheme, an attract, recruit, retain scheme, a GP mentor scheme, and an induction and refresher scheme, along with an increase in the number of GP training paid places of 86% compared to 2015 levels. So we are making progress against all of them. The target is have we achieved what the recommendation said, rather than is there a specific target. Within the contract, there are very specific things that we look to measure, and I maybe would ask Margaret, who may want to just say something about some of the ways in which we measure the success of the contract, because inevitably in a contractual relationship, you'd expect there would be a healthy tension. We're always going to be pushing GPs to do a bit more, perhaps than they would like to do. They're going to be saying, well, if you want that, you're going to need to give us a bit more money. You know, that's the nature of the relationship. But do you want to say something about the core things that we looked to measure through the contract, Margaret, and how your team goes about that?
Yeah, sure. Thank you for the opportunity today. So I'm head of general practice, so I contract with currently 307 GP practices across the region. I have a small team of medical advisors who are based geographically around the region, and we would go out to visit our practices on a 3-yearly basis. Every practice gets a visit on a 3-yearly basis, but also we would look at those practices that we have had perhaps complaints raised about, or there's underperformance issues have been raised, and we would go out and visit those practices in addition to those that are on our 3-year yearly programme. Throughout that visit, we have a set of indicators such as looking at the number of complaints that have been raised within the practice by patients. We look at their performance as it was in relation to the Quality and Outcomes Framework, which we have stood down just this year, and we introduced a new Northern Ireland Contract Assurance Framework. So our visits this year are all in line with the requirements set out. There's 6 domains, one of those being access, and my team of medical advisors with the whole practice team, so that means GP partners, and run through those indicators. We rate those in respect of their performance against them, and will set action plans. There's a plan that goes back to the practice following the visit for remediation, or to feed back the good work they've done. We monitor their what is known as adverse incidents as well. And they come into ourselves for review, and within the practice they also would have to keep a log of number of people registered, number of people they have maybe put off their registration, because there's strict rules around that within the contract regulations. So my team would go out and investigate that.
And just you've mentioned there's 307 practices that you'd referred to earlier. In terms of concerns raised, how many practices have you had to do a special visit to that has had an alert raised about it, for instance, on multiple times?
We'd have the exact numbers to hand, Chair, but typically we would have perhaps less than 10 that would have specific things, be it underperformance in regards to a practitioner, be it that there was an increase in complaints coming from that practice.
For what time period is that, Dr.
Sorry?
What time period are we talking about for those 10, say?
Within the year.
Okay.
Yes.
That's in addition to that, though, there may be practices that are under stress, either because of challenges getting the right medical professionals available or for financial reasons, and there may well be added visits in order to provide support, which is a different sort of a feature to what Margaret was talking about.
Yeah, we also fund the crisis improvement and response team. That is led through the federation, so we work very closely. They also would assist those practices that are struggling and produce an action plan that we work with the practices as well. So that's in addition to our 3 yearly visit rolling programme, the ones that my team would identify and specifically visit, and then we have the practice improvement crisis response team as well.
Okay, thank you. Thank you. Cheryl Brindley?
Thank you, Chair, and thank you so much for coming with us today. So I'm going to touch on patient access and waiting times. So firstly, what steps are being taken, or indeed have been taken, to increase the availability of same-day and urgent appointments? And then I would also ask, how is the department ensuring that vulnerable populations, whether it be elderly, low-income, special needs, have adequate access to their GP?
So perhaps if I take the second one first, access to GPs should be based on patient need first. That should be the governing principle, and we're keen to ensure that everybody can get access within a reasonable time frame. In terms of same-day appointments, we have not everybody needs a same-day appointment, I suppose, is the first thing to say. For some people, this is, this could be something, it can be about a piece of a prescription they would wish to have discussed or whatever, and so it can be fine to wait for a longer period of time. But we do have clear elements within the contract about the time which a practice should be available. And there's a specific set of time set aside, which I'm going to ask Margaret just to go into the detail of, where we would expect on a 5 days a week or 9 sessions a week that there would be availability. Do you want to just say something more about that?
Yeah, sure. The contracted hours for GP practices are 8 to half 6. So the practice will have appointments operating within that time frame. Now, in the fringes, and I refer to the fringes between 8 o'clock to maybe 9 o'clock, and between, say, 6 to half 6, a majority of practices would have local arrangements with their GP out of hours. So that would kick in at that time frame. But within the normal day, from 9 to 6 o'clock, the practices will operate same-day appointments, urgent appointments, but how they would lay that out will be different currently for each GP practice. Within NICAF, as I mentioned just previously there, which is the new contract assurance framework that we introduced for 24-25, within the access domain for that, in order to try and standardise what that looks and feels like for patients, because we all want them to have similar type of access. We've outlined that the practice offers a range of appointment times of a reasonable length on at least 5 mornings and 4 afternoons per week, and practices to provide adequate same-day appointments, triage, virtual, telephone, face-to-face where necessary for the working week, throughout all of the days apart from bank holidays.
And how would that be monitored in terms of the department? If you're aware of a GP or not being able to do that, or they're not offering appointments, or they're maybe having to turn away on a regular basis, would that be through the complaints process, or how would you be made aware of that?
The complaints process is one way of doing that, but there's also data produced and provided to us through GPIP, the general practice site, which gives us an understanding of the activity of GPs and would mean that we would be likely to catch anything that was systemic in nature. I think, Margaret, is that fair to say?
Yes, so I think if I explain maybe what the GPIP is, so it's the General Practice Intelligence Platform, okay? And currently we are able to extract the, let's say, operational codified, so what the GP practices are doing in relation to clinical conditions, which is all anonymised for us looking at it, but that gives us an opportunity to look at the outcomes and the care that our practices are providing. The element that we introduced and is part of our response to the recommendation 1 about putting in a standardised way of capturing activity. That's a new thing we implemented, just took forward towards the tail end of 2023. And we put out a suite of guidance for our GP practices to code, and I'll refer to it as like the appointment module of the GP clinical system, because the clinical systems are there to record consultations and diagnoses and outcomes for patients. But we are using that clinical system now by putting out that suite of codes for our practices to obtain the activity element. So when a patient presents and wants an appointment, we're able to code and pull out how many appointments the practice has given, how many home visits the practice has done, you know, how many times the nurse, etc. So not just across the GP, it's for the whole of the practice team. So we're currently pulling that out of the clinical systems. At the minute, we are also capturing a weekly return and survey activity, which is coming from the practices, but that's more subjective. We haven't been able to turn that survey off yet because there's a few practices that just really need to implement the guidance in a more robust way. But as Peter has said, that's one area that we're looking. We will have a practice dashboard whereby we can look at the activity, we look at their outcomes, and that is one of the areas that would indeed trigger a more targeted practice visit.
Thank you. Just you had mentioned there about practices operating between the times of 8 a.m. to 6:30 p.m. I think. Are you aware of how many actually do that? Would you have that data?
That's their
All
contracted
standard
hours,
contracted
but
hours.
I did mention some of them have local arrangements with their GP out of hours.
It's just an important question because I'm not familiar locally, maybe, of and I'm sure colleagues, I'm not sure if you're aware of any practice open to 6:30 in the evening. That's the reason for us, and that
That's why I say they will have a local arrangement with their GP out of hours. It tends to be around 6
it
o'clock
doesn't-
and it passes
goes
over.
over.
Yes.
Doesn't necessarily mean they're seeing patients at 6:30 in the evening. I think they're just because they're open.
Yes,
so,
yes, that's right.
So that's the other point, I think.
just touch on something as well. You had mentioned about this dashboard as well. So my big concern is about equity of service to ensure everyone's getting equal access to the GP services across the board. Does that dashboard ensure measurement of that in terms of even opening and closing times and various appointments as well, just to ensure that we have equity of access to primary care?
That is the intention, yes. As I said, the dashboard isn't fully operational at this point because we've a few practices just to fine-tune things. But yes, that is the way forward, absolutely.
Thank you. So we heard from the BMA witnesses last week that there was an absence of routine care. So would you be concerned by this statement? And what plans do you have to address this gap in provision of primary care?
Can you say a little bit more about the context in which they described the access to routine care, please?
There was a number of comments basically around the lack of availability, the lack of funding for it, the lack of staff, workforce, mental health concerns of their practitioners as well.
So I mean, I think I understand the concerns there are about the ability to meet the full range of demand that's placed on general practice. And obviously, I've mentioned the multidisciplinary teams, which is one of the key ways in which we can broaden the range of healthcare professionals available in primary care and then meet a greater degree of the needs of patients in a timely way as a result. So the recent announcement about the expansion of the MDTs will help hugely for those areas that are receiving it. We recognise there will still be a number of GP federations that won't be in receipt of the MDT5 in total, and so there would need to be a further rollout that after this 4 or 5 year period of the current rollout in order to be able to get this on a full across the whole of the region basis. But that absolutely is the direction of travel for us as a department and what we would like to be able to do. You may be wondering why it's going to take so long to do that, and part of the challenge is that we have a limited number of healthcare professionals, so the risk is that if we were to go too quickly, you would then be denuding potentially secondary care of mental health, physio, social work skills that they need in order to be able to deliver their normal workload as well. So you've got to see this as part of a joined up system and a single pool of skilled resource, and be careful to make sure that we do this in a way that's sustainable. So we will be going to move quickly this year, and we believe there'll be between 60 and 70 healthcare professionals that will be brought into the MDTs in the next 12 months. That's a rough estimate at this stage. So that gives you some idea of the scale of this and why, therefore, if you tried to do it much more quickly, you could end up, as I said, inadvertently then creating a problem with service delivery in another part of the system.
Thank you. So we were discussing obviously the appointment system, and I know there was some financial investment as well into that, such as triage or the digital kind of
Yes.
consultations. So, do you believe that that has improved patient access? And again, how is that monitored, reported, recorded to analyse whether there is improvements in that access?
So I think undoubtedly it will have improved the situation, but we are also in a situation where I think GPs would tell us that demand continues to rise. So that's a feature of the challenge that we have. I've already explained that some of the measurement of access is extremely difficult because we just don't have the raw data in the way that you would need it. But we would hope through this year's contract that we will be making further progress in terms of establishing some core standards and a core approach in relation to particularly trying to separate, a lot of this is about separating out the channels so that fewer people will need to make the phone call first thing in the morning.
And you had touched on this previously, just regarding some practices may be doing fantastic work, others may be slightly struggling. So just in terms of that, you had said about the best practice guide. At what stage are you? Has that begun? At what stage are you at? And in terms of progression, how long will that take before that is going to be delegated out to the various practices?
I'm going to ask Garo to say a little more about this one, but essentially we've made good progress. We have a near final draft, I think it's fair to say. And we have been engaging with GPs in the development of it. So
the development of the guide, it's probably at a very advanced stage. I mean, it's been developed by GPs taking a quality improvement approach, so it does real ownership from the system for what's in there. It's based on local examples of best practice, covers a wide range of not just kind of how to set up your telephone system, but also how you set up workflows behind that and kind of really optimizing processes. The idea is that it's scalable, so if a practice has an MDT, they'll obviously be able to offer a different range of things than a practice that doesn't, so it should be reflective, there should be something in there for everyone. In terms of implementation of it, if you want to think of it in that way, well, Peter's already touched on, through the contract for the upcoming year, we're looking at making some amendments to really improve access for patients. What our suggestions are, our proposals are based on the contents of that guidance. And I think one of the things we want to do over the course of next year is to really establish a program for to work with practices to help them to change and optimize, and that's still the details have been worked out, but the idea would be not just having it as a piece of guidance to sit on the shelf, but to be a business change program which sit alongside that to help practices, and that would be the idea is that will be rolled out across the region sequentially. But that's the first step is contract for next year.
And firstly, would there be a time frame for that if you can give that? But also, has the Patient Client Council been involved in the design of that document at any stage?
A time frame for the rollout?
The rollout.
Well, I'd say the first step, the guidance isn't near final. The first step will be, subject to agreement, obviously, getting those proposals embedded, or some of those proposals embedded into the contractual piece. So that'll be the first step to making this into a kind of requirements or expectations for the system. The business change piece, we'll be looking to start that in a kind of a pilot sense probably in springtime, but again, it's still to be confirmed. And our capacity, we would roll on an incremental basis, but we haven't really got a fixed timeline for that. The development of the guidance has been led by GP itself, so it's based on the experience of local GPs, and so it hasn't had PCC involvement, but we've got the GP Access Group, which has got patient representation on it. Now, it's not by the PCC, but we have got patient representation there, and they have been across the development of the guidance.
Thank you. Only two left. So, last week we were told on average that in Northern Ireland we visit our GP 9 times a year, whereas in the Republic of Ireland this is around 3 times. So, just in terms of the demand that is placed here in Northern Ireland, what can the department do to assist with that for GPs?
That's, I think, quite a difficult question to answer because that is essentially a societal issue about at what point individuals feel the need to seek a GP access. We have been looking to expand the range of services offered by our community pharmacies, and that's one very deliberate way in which we're trying to find alternatives for some high-frequency concerns that people may come across. I think the model in Ireland is slightly different, as you know. In that there's at least some people will pay towards appointments, and that would be a very significant policy shift and probably taking us beyond the space that we're in today. So I think you're right to highlight that demand for services, it cannot be we need to work through and think more carefully, working with GPs, with primary care more widely, to think about how we provide alternative access means that don't involve necessarily talking to a general practitioner directly. But it is quite a tricky space because public expectation remains very high here.
Appreciate that. So last from me is just in terms of the committee, again, have been told, you've actually touched on this previously in regards to not being able to get through to the doctor, whether that's on the phone. You did say it would be very difficult to manage the unmet need in terms of if somebody rings 200-300 times and they can't get through, it's an engaged tone. But is there any, do you have any knowledge in terms of the department, how much unmet need there is out there in terms of getting that access to primary care?
Well, I think for the reason you've just described, so if 200 or 300, someone phones 200 times, is that 200 people trying to access, or is that one person? It's one person trying to access, and that's the challenge there is in measuring this. So, what we do see is practices offering that if you go online at 11 o'clock, you can actually choose when you have your appointment a week hence, for example. That sort of thing that makes a really big difference to how you can access. But we don't have a means of measuring the number of people who, for example, can't access on a day and daily basis for the reasons you described.
Thank you, Peter, for that. I want to go back slightly just before I go to Anne Forsyth. Dr. O'Brien, in relation to the dashboard. So when, I know you say it's not fully operational yet, but when will it be fully operational? What will that look like for patients, for instance?
Well, the dashboard I'm referring to would be for the practice and,
Yeah,
and
okay.
for ourselves. And I hope to have it operational in the 25-26 year.
Okay. Okay, thank you. Anne Forsyth?
Thank you, and thank you all for being here. Access to GPs in Northern Ireland is the front line of our healthcare system. It's the day in, day out experience of patients, and where we are at the current time, it feels like we're in absolute crisis. People are coming to constituency offices. We've launched a survey. The attention to that has been absolutely huge, and where people are feeling they don't have confidence that they can get access to their GP, it gives them a terrible perception, of the whole healthcare system, and people are under immense stress. And I'm just really concerned, whenever we're talking about this, and we had it in last week's evidence and we have it here today, and we're talking about the likes of this dashboard, and it sounds like the bureaucracy of it, and the managing contracts and the managing of the data. I am really concerned that we're actually losing the patients in this, the patients who are trying to access their GP, people who are sick, people who are vulnerable, people who are genuinely worried about their health, their children's health, their parents' health. And I just want to know, as Department of Health, what are you doing to actually capture the patient experience of all of this?
Okay, thank you for the question. I think, to be clear, something like the dashboard is really a separate issue. That's a management tool to assist the department in the overall performance of general practice, and not, while access is one of the domains, it is only one of the domains. You're absolutely right that patient experience is really important, and again, we do have means by which we try to gather information about what the patient experience has been, and Margaret will say a little bit more about the detail of that in a second. And we measure and monitor that practice by practice, because I think one of the risks here is that because we've all heard at least one bad story about someone having access to GPs, that then gets conflated to nobody gets access to GPs, and that just is not the reality. Our general practice and the staff who support them work incredibly hard to ensure that as many people as possible get access in a timely fashion through appointments on the same day where that is needed, and so on. So there is an awful lot of demand that is met, and met in a very good way. And I think while I understand the concerns, and inevitably the hard stories are important for us to hear and to look to address, it is also really important that we don't talk down what is being delivered in primary care, because 200,000 appointments a week in a standard week, more than that during the winter where we invest additional appointments because of the additional demand. If you think that's in a population of 2 million, that is a very high number of appointments that is provided. I don't know, Mark, could you say something more about the patient experience and how we monitor that?
Yes, so patient experience currently, so maybe just to outline what is currently in the contract in relation to the GP practices. They are required to provide services and manage their registered patients, and any of those who are temporary residents who believe themselves to be ill or are actually ill. So, I mean, that's what is the requirements as stipulated. In order to gain true patient feedback and patient engagement, we are planning for the 25-26 year to introduce that individual practice engagement with their patients. And that is part of the discussions we're having with the GPC committee currently, to negotiate in actual requirements for practices to engage with their patients, survey their patients, learn from and take on board comments back from patients, and introduce some actions as a consequence of that. Perhaps a patient participation group at each individual practice to gain those that true engagement at that practice level. Currently, the mechanisms that my team would engage with the practices on is around monitoring their complaints, monitoring any adverse incidents that occur, monitoring what we term significant event analysis. So that's at individual practice level, which can be positive or negative. And they also take account of patient engagement and outcomes for patients at that individual practice.
Do you think that there should be more of a role for the Department of Health in terms of access and patient experience? Because I hear what you're saying, but my experience of dealing with GPs is they have an awful lot of administration tasks as it is, and this would be another one for them. And when they're producing that data, does that need to be audited by someone? It's extra work for everyone. And I'm just, asking as a Department of Health, is there something there that you feel a responsibility where the department should be?
So I think the answer is in two parts. The first is in relation to the administrative burden. We do look very carefully at the administrative burden we place on general practice. And for example, last year we ended the practice in relation to the gathering of information under what's called the Quality Outcomes Framework, because GPs said that was proving too onerous for them. We listened and we acted. It was their number one ask at the time. In relation to our role, I think that my suggestion to you would be that the way we do it is the right way. So I think if I was a general practitioner, I would want to know what my patients thought about the service I was giving, and then for the department to act as an oversight mechanism to test that, rather than for everything to be drawn up to the centre, and then for the GP practice not to have the sense of ownership or the sight over that. So I would suggest that that's a more appropriate way of doing it than to centralise it.
Well, the difference of opinion, I would think that the Department of Health would be concerned over how many patients in Northern Ireland feel that they're accessing their frontline GP care. But
I'm not saying we're not interested or concerned about that. I'm saying the means by which we should seek to access that is through reporting from the mechanisms that we've got, rather than to introduce a different reporting mechanism, which is what I'd understood you to be suggesting we would do.
Well, thank you. And there's ongoing concern patients are often accessing healthcare services inappropriately. So attending emergency departments for issues that could be managed by a GP, or visiting a GP where a pharmacist could have provided the suitable care. And I just wondered, what is the department doing to educate the public on how to access the most appropriate care?
Well, at a general level, we do a lot of messaging, as do our provider trusts and our general practitioners and indeed pharmacists, about what services are available where and what's appropriate to try to manage that. I think inevitably what we also then need to do is to supplement that with more personalised one-to-one guidance when people do appear at a location that perhaps isn't the most suitable for their needs, to be given advice and guidance about how this could be done differently and better without their being made to feel bad about it, because it may be just that they were unaware of the range of things that were available. It's in the nature of this messaging that some people don't pick it up, because until it actually applies to them, they don't necessarily go seeking it, and it's not something you can necessarily force everybody to be aware of. So it is an ongoing effort that we make to try and manage that. As I said, I think there are different ways it needs to be done.
And do you monitor and measure, the numbers that we're talking about there? Like, would there be a survey, for example, in an A&E department, how many people that were in during this shift could have been dealt with or should have been dealt with at a GP?
I think that probably, I suspect that data is not available. I would need to check whether we have that data. I suspect the reason it's not available is a lot of these are judgment calls. It's not necessarily, some cases will be very clear cut, but others might be marginal calls, and it could be quite bureaucratic and time consuming to ask people to do that kind of an analysis. And to try and work out which side of the line does that really fall. I think we don't have that data, but I can by all means check that.
And then it's just, if you're not capturing that or gathering it, how do you measure the effectiveness of the efforts that you're making in terms of educating people on accessing the most appropriate healthcare?
I think that there is, it's in the nature of that kind of public information advertising, that you can test the extent to which people have read it and understood it, but it's very difficult to test the extent to which people apply it when they're in a particular situation where often they or a family member are unwell, and perhaps they then become less certain than they would have been if they weren't in that slightly stressed situation. So it can be very hard to measure that in practice beyond understanding how many people have accessed the information.
So in terms of the people who are trying to access GPs, but actually they perhaps don't need to access GP, they should have went to a pharmacist, or they should have taken another route, and we've got this pressure on the system. Is there no way that you have in place at the minute to measure?
I don't think that there's a means of measuring that for GPs. Certainly, you would often expect perhaps that the receptionist at a GP would be able to provide that advice and guidance to an individual. There is data on all of the GP websites that signal the kinds of things that are suitable for contacting a GP. So we make every effort we can in that way. But as I said, it's not... I think we would end up chasing our tails if we tried to put some big bureaucratic mechanism in place to try and measure it.
No, absolutely. And what's the extent of engagement with the Patient-Client Council on access to GP services?
So there's been, I think, Garode, you briefly covered this just now. There is a GP access group which has patient representatives on it. We have met the Patient-Client Council, but they're not formally members, and we are looking at how we engage with them going forward. I think it's fair to say.
That's fair. So I mean, I mentioned the access group, and that's from the inception. That's equally parts GP representatives and patient representatives, not PCC, but it does have direct feedback into it. I think the other thing is that we are, as we look around the future for MDT implementation, we will be looking to see where can we add in our governance structures to make sure the patient voice is captured in that. So I mean, it's somewhere where we can strengthen the current arrangements to give the patient voice in all the deliberations.
And we were told that the complaints received by the Patient-Client Council about GPs have increased, whilst complaints registered with the SPPG are declining. What assurances can you provide this committee that it has adequate oversight of the quality of GP services?
That who has adequate oversight?
That the department.
We can provide you with the sort of information that we've given you about how we do oversee the contract on a practice by practice basis, the nature of the quite extensive interventions there are by Margaret's team. Both on a generic basis to make sure everything is okay once every 3 years, but then on a more targeted basis depending on any evidence that does come to light. And certainly if the PCC had any information that it wanted to share, then we would be very open to receiving that. And I'm happy to commit that we would engage with the PCC to make sure that that link is made, so that if they're getting a pattern of complaints, we're aware of that and can take it into account in case that has not been made aware to us.
It all feels quite general, and again, as I say, it's your patients we're talking about. It's the specifics of their access to GP services here, and why these things are general just seems to be a real lack of specific data and action to drive straight back through. And whenever I go back and speak to my constituents in South Down, I don't know, is there anything you can say to me that I can go back to them and make them feel that their specific issues are being addressed, where I've got towns where there's 2 or 3 different GP services with completely different service provisions and different levels of complaints, different levels of issues coming to my office. So is there oversight coming from the department?
There is oversight, and we've tried to set out today the nature of the oversight. We've also explained that through this year's contract arrangements, we're seeking to create a benchmark where there's the same expectations placed across all practices to try and reduce any variation, and we will be looking to build on that in future years. So we're absolutely working hard at this. It is a complex and challenging area, and it is not amenable to simple answers, I'm afraid, of the type that perhaps some of your constituents are seeking.
Yeah, I know, and appreciate, and it's the governance. You have Department of Health, you have the different trusts, you have different practices, and I think that's somewhat of the challenge that has been caused by it. Thank you, Chair.
Thank you. Dan, just in terms of data collation and the complaints, and this is a bit of a mixture, but have you any data on, for instance, the number of patients being diagnosed with cancer that are diagnosed at a later stage now compared to pre-COVID? Have you seen an increase, for instance, in the levels, given that they can't get access, say, to a GP, which is normally the first point in which someone is referred on?
So there will be data on when people, which stage cancer people are diagnosed with. And there certainly was, I think, I did hear that in the immediate aftermath of COVID, there had been some increase of late diagnosis because perhaps people had not sought to access health services. I'm not sure I agree, though, with the second half of your point, which is the reason for late diagnosis is they couldn't access a GP, because I'm not aware of any evidence that suggests that there's a causal linkage between those two aspects, and I would be doubtful that there is such a linkage. But I don't have the cancer prevalence data available today. It wasn't one of the areas because it really takes you into the secondary care space rather than the primary care space.
The point I'm making is if someone has some form of symptoms and can't get access to their GP at an early stage.
If that were to be the case, obviously that would be a problem. But in practice, what we've done is we've created rapid diagnostic centres. So where a GP sees a patient and they have concerning but vague symptoms, there is a means by which they can then be fast-tracked through to one of two facilities, one at White Abbey and one at the South Tyrone Hospital, to enable the proper checks to be done and for it to be clear whether or not there is a cancer or indeed another diagnosis that emerges from the sort of scans that they would have as a result of that.
So just in terms of that general area that I've just mentioned, in terms of the point of diagnosis, I'm going off a wee bit slightly here, but I know there's a fine line between the primary care element of that early diagnosis and ultimately the secondary care treatment that is required for somebody. So does the department monitor, I just want a wee bit more information on, you said you monitor the stages of diagnosis. So in terms of late diagnosis, post-COVID, they increased slightly. What are they like today? We're 5 years after COVID, for instance. So
look, I'm not going to pretend to have the data in front of me. I'd rather write to you with details of what we do hold in terms of the extent to which there is more late diagnosis of cancer now than there had been previously.
I would appreciate that. Thank you. Okay, Tom Buchanan.
Thank you, Chair, and thank you for coming before committee today. With regards to regional disparities and equity of services, what data then does the department hold on variations in access to GP services across the different regions?
Well, I think that essentially we're coming back to the fact that each practice provides a suite of information to the department. We look at that on a practice-by-practice basis. There's no presumption, and I think no evidence to suggest that there's a difference in terms of access by area overall. But we know that in some areas the provision of GP services has been more challenging, particularly in some rural areas.
What help have you offered those practices that are more challenging whenever you've got the data presented to you?
Margaret has set out, and I'll ask her to say a little bit more about the support of the intervention team that sits and is run out of the federations, but funded by Margaret. And that is the core way in which we try very hard to ensure that practices can continue. Inevitably, there will be times when individuals are just towards the end of their natural career, and it may be challenging then to find a successor, or if a partnership breaks down. But do you want to say something more, Margaret, about the work of that intervention team?
Sure. Maybe if I start with a fact just to explain that as GPs or independent contractors, we fund them in an overarching amount of money. We do not set the number of GPs that they would have in place, the number of practice nurses, or indeed the makeup of their team that sits with the independent contractor to put in place. Additional resource that we give to those practices that are struggling would be through the crisis improvement and response team. I fund that to the tune of 950,000 per year, and it helps those practices for a variety of reasons, because the practice is struggling for a variety of reasons. It can be that their operational processes aren't optimum, can be that it's a single-handed practice or even a two-partner practice, and unfortunately there may be sickness that has occurred within the GP partners. So there's a variety of reasons, but the crisis response and improvement team will go into that practice. They can offer that practice GP cover. There's an experienced practice manager that works as part of that team that can go in and help them optimise their flows, patients, their administrative work, and they usually set out an action plan with that practice by way of how they can improve going forward.
Well, looking at, in particular at rural and deprived areas, what measures have been taken to address inequalities in access?
So what are the inequalities in access that you've identified?
Inequalities in access to the GP services and for example, in rural and deprived areas.
So I suppose what I'm asking for is the evidence base that suggests there is such a difference.
I share a constituency with Tom, and in more rural parts we find a number of complaints in terms of access to their local GPs, but there's been issues in some of those areas, which would probably be Tom's follow-up question. Those surgeries or practices have become at risk. GPs have handed back contracts, etc. So there's been an inequality of access, I suppose, in those particular areas, is what he means.
Okay, so
there's challenges in rural parts. To use the Western Trust as an example, not to be parochial, but there's unique challenges in rural areas.
So look, but the point is that in those, as a result of the work that Margaret and her team do, there is still a provision of general practice, a full general practice service across all of the region, whether you be in a rural area or not. Of course, in a rural area, you may travel a little bit further to your GP, but I think the figures are that 88% of the population live within 3 miles of a GP practice and 95% live within 5 miles. So, yeah, we are talking very substantial numbers who are very close to a GP. You're right to highlight that in parts of Fermanagh and South Armagh, there have been some challenges in relation to finding GPs who wish to step up and become partners in those practices, and so the Western Trust and the Southern Trust do hold a number of contracts, but they want to pay tribute to the work that they have done. In particular, the Western Trust, I think, has really taken some important leading steps, seeking to recruit salaried GPs to provide continuity of service in their area, and that has demonstrated through 2 different rounds of recruitment good success. So I wouldn't want anyone to be left with the impression that because there have been some of those challenges, that somehow there isn't a service being provided, because it absolutely is.
Yes, but to touch on, I think what Tom is getting at is, for instance, if you're a GP in a rural area and you are a single GP in one practice and you have 3,000 patients, then it's going to take a significant period of time to get an appointment compared to a person in another area that has access to 3 GPs in the same practice. So in terms of equity, how are we ensuring that everyone has the same access to their GP, even in terms of numbers of population?
So there are practice lists or sizes, but that you wouldn't find that there's such a big differential as perhaps the question implied, that one GP would have a list of 3,000 and another would have 3 GPs for the same. They would likely have 3 GPs for a lot larger practice size than that. So it is true, I think, that some of our learning has been that single-handed GPs are inevitably going to be a little bit more vulnerable, either to an individual, perhaps, as I said, looking towards retirement, or perhaps facing some challenges. And where it is possible to do that, we therefore do look to bring together practices to make them have a larger number of GPs, because that adds to the stabilisation of the service. And I don't know if you want to add anything to that, Margaret.
Yes, if I may, in order to support those practices and aid them in maybe attracting and recruiting additional GPs, we have introduced an attract, recruit, retain scheme, whereby it can facilitate help for that practice to either obtain a partner or a salaried GP. So we offer a 40,000 additionality over a 5-year period if a GP goes to that practice to become a partner, and a 20,000 additionality. So call it a golden hello, if you may, for a GP salaried to retain, be part of that practice for a 5-year period. It also helps with relocation costs. It helps with advertising for GPs, etc., to those areas. Now, it's not just for rural areas; it's across the region. But it has been very successful. We've had 82 practices avail of it. 52 of those have recruited additional partners and salaried GPs.
Okay.
Thank you. Yeah. In recent years, then, we've seen GP practices handing back their contracts. Why do you think that has been?
So you're right, we have seen a very substantial increase both in 22-23 and in 23-24, where we were in double figures for both years. We have seen a substantial reduction this year. I think we're five this year. We hope that the steps that we have taken working with general practice to address some of their concerns have been helpful in that respect. We certainly believe that the spreading of the multidisciplinary teams will be helpful, because we've seen far fewer contract handbacks in areas where there is a multidisciplinary team in place, because that provides a broader base for general practice. But I think the answer to your question as to why we've seen is that in part the age profile, we'd seen a large number of GPs at or beyond retiring age, and perhaps a greater number had chosen to take up the retirement option, potentially in the immediate aftermath of COVID. That was a very stressful time for our health and social care system, added to which there are high demands on primary care. The sad reality is that all parts of our health and social care system are under really significant pressure at the moment, and we've seen that. I'm sure that will have played some part as well in the contract handbacks. But as I said, the work we've done, I believe, has put in place some important building blocks. We're still working at some further building blocks in the context of this contract negotiation, and we've expanded the support that's available to general practice in order to help get beyond that. We've been helped by not just the Trust, but by a number of the GP federations that have really stood up and helped to take contracts forward where there's been no immediate partner, often with a view to ultimately creating a partner model. But we try to work as part of a wider system here, work with all of the different players in order to make this, to reduce the likelihood of contract handbacks.
Yeah, not all contracts that were handed back were from GPs that were retiring age. There was younger ones and that was handing them back, simply because of the pressure, as you said, that was on GPs. And while we welcome what the department are stepping in now to assist GPs, do you think it's a bit late in the day?
Well, all I can say is there's been very active work done throughout, and of course you try and learn and work out what it is that will make the difference. We have to remember that we've been working in extremely financially constrained circumstances that has made some of the more obvious steps that you could take very hard to deliver, given the risk of not being able to live within budget and so on. So I wouldn't personally agree with that. I think we've absolutely done the best that we can in the circumstances, which have not been easy.
And when we take a trust a practice that the trust takes over, or a contractor-run practice, what's the difference in cost?
So we've provided some information to you just in the last 24 hours in response to a request. It is true that some of the costs are higher. and have been higher. So what we've looked to do, and that has often been because in the short term it was necessary to put GP locums in, and the rate for a locum was substantially in advance of that would be payable for normal GPs. Just similar issues apply in secondary care as well. We have reduced the amount paid per session to locums in the last year, and we continue to keep that under review. In an ideal world, we would be reducing and phasing out the use of locums, but you will understand that our first priority is to ensure that equity of access for patients that you started your questioning about. So we can only do that in circumstances where we can be sure that we can deliver a suitable primary care service in that way.
And just one other issue was whenever a GP practice was in difficulty and was at the risk of failing, would it not have been better for the department then to have stepped in and helped that practice to stay in place rather than to let it fail, if you like, and the department take it over?
So let me assure you that the department makes every effort to do that through Margaret and her team, often very successfully. So there are large numbers of contracts that could have been handed back were it not for the efforts that Margaret and her team have made. But there are times when that is not possible, and then we need to look at putting in place the arrangements that secure primary care, general practice for the population of that area. And again, there's been huge success in ensuring that primary care does remain available across the whole of the region, and I think we should recognise that.
Yeah, and we do welcome the fact that the department has now taken a greater interest in GP practices, perhaps maybe than in past days.
I'm not sure I accept that there's an increased, I think that there's been a full-on attention to general practice throughout. Certainly in my 3 years in this role, I've spent a lot of time focused on how we address the challenges that general practice are facing.
Thanks, Tom. I think Tom's talking about the longer term. This is not a new problem. It's something that has been an issue for some years. And often, unfortunately, with some elements of the health service in Northern Ireland, the response often ends up much more costly than actually a plan that could have been in place much sooner. And we're seeing, just as indicated, the response to the GP crisis could end up costing us more money in the long run than actually putting in place proper arrangements that are supporting our GPs and the work that they do currently, which is actually the feedback that we have had from GPs last week at our previous session. They don't feel supported, and they don't feel that they've got the resources available to them to deliver on the demand that is, or to meet the demand that is before them.
So I think, Chair, you'll understand on the resources point that it is in the nature of a contract negotiation that the contractor is always going to suggest that they need more money for the service that they are being asked to deliver, just as you would want us to be pushing to make sure we get the best possible return for the public pound that is spent in terms of how much service we're able to secure through that contract. That is a natural and important tension, and one I would imagine that this committee would want us to maintain while being reasonable about it, because otherwise we would end up just essentially giving GPs what they asked for, and that would not necessarily guarantee the best use of public money.
I don't disagree with you on all of that, but there's some elements that I would have concern about. When you do look at the figures in relation to the demand on GP services, they have increased. There's less GPs to deal with the demand, and also
there are more GPs than there have been.
And practices?
There's slightly fewer practices, but there are more GPs. It's true that more of those GPs work less than full time. But just to be clear, there are more GPs than there have been.
And is it also fair to say that GP practices, and we'll get to this later in the evidence session, but is it fair to say that GP practices in Northern Ireland are less funded compared to their counterparts in other parts of the United Kingdom?
We will get to that. I think it will depend a little bit on what base you use as to whether that's the case or not.
Yes, there is an issue here which we will get to. Thank you. Colin, briefly.
Just in terms of follow-up to that, and they do, Permanent Secretary, accept totally the need to apply a good housekeeping in terms of, however, what the GPs I think were indicating last week was that we're in a context, and I accept there are more GPs, however, people are living longer with more complexity. You have the issue of people living on, a lot more people on waiting lists and comorbidities. So in that context, a crude more calculation may not be sufficient. So I suppose the question is, do you believe that with all those factors added, that they have sufficient resource? And I'm going to be coming on to MDTs, so I'll come to that. But just I want to put it into that context around older population, a growing population as well. Don't forget.
So look, we've had many conversations over the years about not just GP investment, but investment across the full range of health and social care services. So if I tell you that I have sympathy with some of the arguments made by GPs, I also have sympathy with arguments made by pharmacists, by dentists, by social care providers, by our elective care waiting list problems, by our urgent and emergency care problems. So the reality is that there are lots of different ways in which we could spend additional money. At the moment, and the Assembly sets the budget for, and members of this committee set the budget for the Department of Health, we do not have additional money to spend on those things. So I think the challenge, and it's ultimately, and I'm not copping out here, but it is ultimately a political challenge about prioritisation, which is where should the money be taken from if we are to give extra money to deserving causes. And I'm not walking away from the deserving causes there are across the whole of health and social care.
But just to follow on from what Colin and Tom have pointed out here, if there isn't a serious recognition of the challenge then the GPs are telling us, as they did last week, and obviously the knock-on effect that it's having on our public, more and more GPs could hand their contracts back, which in the long term costs the department and therefore the taxpayer more money. Is that not the case? Because that's what I'm seeing here in figures.
So the first thing is, of course, there are risks to all parts of our system that if they don't get more money, it could be that it ends up making things more difficult. But we have taken a series of measures over a number of years to stabilise and meet the concerns of general practice. When I came into the role, the quality outcomes framework was the top issue in terms of money was provided separately at the end of the year in return for GPs demonstrating against a whole raft of different measures how they delivered things. So in response to that, we froze that and didn't make that a requirement, and then in 23-24 we moved the funding up front, made it no longer conditional on the quality outcome framework. We used the new assurance framework that Margaret has talked about instead. Secondly, we have made a contribution towards indemnity payments this year, and we have provided additional funding on an in-year basis for each of the years that I've been in post, obviously subject to ministerial agreement. So I would want to reassure you that we do take seriously the concerns that are raised. We do act usually based on what they describe as being the main issue for them at any given point. It is true that we are not generally able to meet all of the concerns they raise, but then that is also true for all of the other different parts of our system that I have described too. So I would just want to reassure you, this is a department that has listened and has acted based on what we've heard. As I said, I believe that has progressed things. We still would ideally be doing more. I also accept that, but we are facing some hard choices as I've tried to highlight.
Yes, I have no doubt. We'll touch more on finance later. I'm going to let Cathal Boylan come in now. Okay, Cathal?
Thank you very much, Chair, and you're very welcome. Thank you very much for your contribution so far. I just want to touch on locums. Yep. So in terms of your own practice, trust fund practices, can it be the same doctors who hand the contracts back, who go back in as locums?
Oh, sorry, could you speak towards the mic, because it's very difficult to pick it up.
Sorry, Chair. No, just can those contracts are handed back? The trusts now that use locums, can they go back in this system? Yeah.
There's nothing in employment law that precludes that from being the case. I don't know if it's actually happened in practice or not, but
It has, yes. We have certain practices where they've handed back the contract, and currently there's some of those that the outgoing partners are now providing locums.
Does the department incentivise handbacks?
I don't think so. We try very hard to make the model that we've got work, and as I said, we are looking to introduce, where we can, salaried GPs as a more value for money alternative to the use of locums.
So you don't incentivise them? How do you manage then those that you take
Well,
back in?
sorry?
How effective is it then? How do you manage those that you take back in? So those people who hand back, do you just take over? Or you're saying you don't incentivise handbacks, yeah?
There's no funding provided to people who hand back their contract, if that's what you mean by incentives.
See, given the growing reliance on locums, okay, to fill in the gaps, how does the department assess the cost effectiveness of using locums compared to, say, long-term solutions of, say, recruitment or retention?
So our preference, obviously, is to avoid contract handbacks in the first place, to avoid the need for locum GPs wherever it is practical to do so, and to use alternative mechanisms, including recruiting, as I said, salary GPs, or indeed identifying GPs who are willing to become partners in practices. So that's our preference. But we do need to make sure that we can provide a service right across the whole of the region to all of the people who need access to general practice. And so there are times when locums are, as it were, the least bad solution, if I put it that way.
Just a final question on the use of locums. Do you think it impacts on the quality of care?
So I'm going to ask Margaret to say something about that, because obviously we monitor all of the practices, and I'm not aware that we have any evidence to suggest that there is worse care from locums, but I'll ask you to say something about that.
Yeah, Peter, you would be right. It may impact on continuity of care because patients are, introduced to a new doctor. But as you pointed out, Hal, that in a lot of instances where the contracts have been handed back, those outgoing partners are indeed providing that locum cover into those practices, which we cannot, there's nothing we can do. They've stepped into a different range of employment, being self-employed, and that has an advantage in that for that period of stabilisation of a practice until we're able to recruit salary GPs, those patients are still getting access to the GP that they would have seen previously.
And that's part of the problem, because we should be looking at longer term solutions, to be honest with you.
Yes,
training up, and that's why I asked the question in the first place.
So, well, to be clear, we have increased the number of GP trainees very substantially, and that is with one of the answers to that. And we have a whole range of different ways in which we seek to retain, recruit, attract, induct, mentor GPs in order to try to maintain them and to maintain practices and also to make this an attractive career option for the future.
Thank you. Thanks, Chair.
Okay, I have a number of just supplementaries in relation to this, because this is the hot potato of the whole session, I think, to be honest. So first of all, when it comes to access, do patients at practices have similar access to services available through a standard GMS contract, or what is it? What is available? Reduced to constraints, for instance, on recruitment, locum availability and cost.
I'm not sure I quite understand the question, Chair.
So when it comes to the access, do patients at various practices have similar access to services available through a standard GMS contract, or what is it?
Yes.
It's the same throughout.
Yes.
Regardless if it's locum, GP, whatever.
Yes, that's right. If I may just add to that, so we have two contracts. We have a GMS contract, which is General Medical Services, and we also have an APMS contract, which the trusts would contract with us for. the contents of which are exactly the same.
So back to the locum stuff again as well. So can or do those GPs who hand back and return as locums then become salaried GPs, or do they remain as locums?
Well, that will be an individual decision. It's not something that's determined centrally.
So, in terms of the disparity between, salaried vs locum costs, it's obviously more cost effective for the department or for the trust or the practice for the department for salaried GPs.
Yes.
So surely the incentive there is that they remain as locums because there's more money in their pockets. Would that be right?
Well, it will depend on, as I said, very much an individual choice. Clearly, a locum may not be necessarily offered full-time work. They may be offered sessional work rather than working every session.
£150 a session,
Yes.
and the maximum they do is 9 sessions a week. So just say a full-time locum, we'll just say there's a full-time locum doing 9 sessions a week at £350 a session, which is 160-something thousand a year. That's a fair incentive over a GP salary at 102 or 98.
Yeah, salaried GPs will have access to holiday entitlements, holiday pay, pension, and so on. So the gap is not as large as you might imagine. But yes, there is, of course, something of a premium. And as I said, some GPs will only be offered locum work on a sessional basis rather than on that sort of more full-time basis.
I think just to add to that, I think we've seen from the example in Western Trust that where it was primarily locum led, once there's been salaried roles available, it's been a very popular option. So I think you're right in that, purely on the numbers, it might look like there's an advantage of being purely locum, but I think the experience shows different.
Well, the devil will be in the detail. How many locums have we got employed as GPs?
I don't have that information today.
Well, if we had a breakdown of the cost of the last year, it would probably give a true reflection of the challenge that we're in. The real concern that this committee has is as to whether there's an incentive here to move as a locum effectively and not, to hand back contracts, for instance, in one state and come in as a locum in another, which is going to cost more money. It's incentivising the closure, in effect. It could be said.
Well, I think that we can certainly give you information on the scale of the use of locum GPs if that's helpful to the committee. But I think you'll find that
Useful.
we've
down per trust.
got about 1,400 or 1,500 GPs in total, and the number of locums would be a small proportion of that.
Yeah, we have about 2,000 GPs on our Northern Ireland primary medical performers list. So there's probably about 300 or 400 of those that choose to be GP locums. The detail of who would employ those GP locums sits with individual practices. Sheriff, I think what you're asking is in the temporary period of time that trusts would hold the contracts, and in order to ensure that there is GPs on the ground, they will employ them as locums in the first instance until they're able to get together an appropriate JD, advertise
Job description
as employment law requires. And indeed we find a great uptake from the Western Trust practices in regards to those salaried, which means that those locums will not be used. They will work with the GP salaried GPs.
Has the number of locums increased over the last number of years? Has the trajectory been upward?
As I said, because inevitably any practice may need to use a locum for a session in order to fill in for a GP who's doing something else. That could be because they're representing their practice or the GP community. It could be that they're attending an event on behalf of the department, including some of our committees, where on a sessional basis you would have a locum who would come in and fill in, and that would be entirely normal, exactly the same way as it works in secondary care. So we need to be careful here. Our objective should not be to say locum bad because some level of locum is going to be needed.
Please don't misinterpret what this committee is doing. We're not saying locums are bad. What we're saying is there a trend in GPs leaving and becoming locums and ending up then costing the taxpayer, which is what we're responsible for, more money because the Department of Health didn't put a proper plan in place to support GPs at an earlier stage. That's what I'm concerned about.
Well, I understand the question. The point, though, I'm trying to make is that some level of GP locum will always be needed in any system. We recognised that the rate we had been paying for GP locums was too high, and we've reduced that rate accordingly. And as I said, we work actively, and the Western Trust has done a really good job in terms of seeking to move more of those GP locum roles into salaried roles, which is demonstrating that there is an appetite for that, and one therefore we will be looking to roll out more widely as we go.
I'm concerned as well, Dr. O'Brien, did you say 2,000 GPs? You estimate about 400 of them are locums?
About 300 odds, yes. Choose to be work as what's termed a portfolio career.
Yes.
And
So
do
these
GP
Some of them
locums
will
and-
be working sessions, that's no doubt, and probably
Quite a lot of them will
considered.
be retired. People who've retired from their normal practice who just keep their hand in by doing a few sessions a week or whatever it might be. Is that
yes,
fair?
and it can be even younger GPs who choose to work as GP locums and do other roles, such as, you know, take up a role in secondary care, deliver in, you know, a specialty service, etc.
It would be fair to say that some of those locums are working full-time, all year round,
I'm sure that's right.
at an increased cost to the taxpayer. That's the point I'm getting at. Yeah. Okay, Colin?
So I fully accept the point that there are appropriate uses for locums, necessary uses and valuable uses. And you have touched on the issue of locums, the rate of pay of locums, but what I think what we're trying to get at, is there an over-reliance on locums generally within the system?
So we're trying to avoid there being an over-reliance on the use of locums through the kinds of means that I've described. And I would just highlight that locums who are working full-time are delivering a service to that part of the community that needs...
Again, that's not in question.
No, I'm just explaining. It's really important, though, that we recognise that there is a worth and a value in what they are delivering for our society. Yes, of course, we would like, just as we would like there to be less use of locums in secondary care, we would also like to reduce the use, not to eliminate it, but to reduce it in primary care. And we believe through things like the salaried GP, the growth in salaried GPs, there is a viable means of looking to build on the successes we've had in achieving that. But inevitably, we are talking about choices that individual practitioners get to make. If they choose to end their time as a partner or a full-time practice on a normal basis, then they can do so, and we would not want to stop them from being able to provide services in another way because of the skill set they have.
Yeah. Basically, this is a value for public money question,
Yes.
really. And that's the nub of what this committee is about. And we have concerns that there's an incentive here, and unfortunately, the numbers are higher than most of us would like. We appreciate the role of locums and cover sickness and paternity and all those, and they do an exceptional job. Just to put that firmly out there, we agree with that, but the numbers are high, and I would actually be very keen to see what they're like compared to other jurisdictions as well. And I would like to see a breakdown of the costs, if possible, in a greater scale.
We'll see what information we have to be able to provide to you. As you said, some of the information will be contracts, practice specific, and I think they don't necessarily have to share that with us. So.
Yes, and just in terms of your letter as well, you've indicated the rising costs of trust managed practices have increased 4.7 million. Is that correct? On trust run GP practices in 23-24, which is an increase of 959,000 in 22-23 alone.
That's the total amount paid to cost, the total cost of the trust.
Yes.
To the
So-
trust.
why-
It's not a comparative cost.
Why has the cost of trust-run GP practices increased almost fivefold in a year?
It's because there are more practices being run by trusts in that second year than the first year. So of course the cost will be greater.
Yes, and do you expect that to increase?
As I said last year, this year 24-25, we've seen a reduction in the number of contract handbacks. So I would hope that that would not be the case. Trusts are really a port of last resort. We seek first to secure new partners for the service. We then will work with the GP Federation to see if they can take over that contract. And it's only failing that we will turn to trusts because it's not their primary business. So it's not the ideal, but it is still better than there being no provider of primary care in that area.
And there's examples of it in Tom and my constituency as well, so yeah, okay.
Chair, just on that, does the trust use
Yeah, Colin.
locums, or are they practices that they take over?
It will initially, as Margaret explained, until they've got a job description and can work that up. It depends then on whether they're able to find someone who's willing to come in on a salaried or it still remains the ideal that we'd return to a partner model, but that may or may not be possible. It may be that we are seeing a shift in the business model for general practice to more of a mixed economy than we had previously, where all practices were run on a partner basis.
That could explain the rise in cost.
It's because we have had to ask trusts, particularly the Western Trust, to run more contracts in 23-24 than 22-23 that you've seen arise.
Yeah, and we're very conscious of it. Diane, and then Colin, you want to supplement? Is that right? And
I'm
then
coming
Kevin.
in at that point,
Yeah.
just on this issue.
Yeah.
Yeah, no, thank you. And I just wanted to ask in terms of, we mentioned like the quality of care and the patient experience on this. Do you have any data or capture anywhere where a patient goes in and gets a locum rather than their normal GP, and then that hasn't satisfied them, and then they continue to try to access to get their regular GP?
Well, often if there's a locum, their regular GP won't be there or won't be working in that.
Right, just maybe rephrase my question. So, if I'm trying to, get an appointment and I get the locum, and actually, when I didn't know till I got there, I got the locum, and then I actually then want an appointment with my GP because it was my own GP that I wanted. Is there any data around that?
I suspect not, but the picture, as I think Margaret has tried to explain, is a bit more complicated because sometimes the locum will have been a GP in that practice before, and it will therefore be an advantage because you'll be getting to see the GP that you've always seen, and you're not going to be worried about the basis on which they're employed.
Yeah, no, and it was just as a wider point as to, the quality of care piece. I know myself, I've got an excellent GP, and on a couple of occasions, I've been very fortunate that he knew when he saw me that, I wasn't as I usually was. So to me, that is a higher quality of GP service. So if I'd showed up and maybe just got my stats taken by a locum, they wouldn't have known my wider. So it's just the quality of care piece in terms of, just wider locum use, not necessarily on contract handback. So it was just asking if you captured any statistics around that. So
Not aware of any statistics. Margaret did highlight that there could be some loss of continuity of care in some situations like that. And that is a challenge. It's equally going to be applicable for a maternity leave or a sickness absence, so it's to some extent unavoidable. But we track patient outcomes through the work that's done. So if there was a clear divergence, that would show up. But we aren't able to track patient satisfaction, for example.
well, thank you. Just in terms of, people trying to get through, and I just wondered, was that putting extra pressure on the system? Thank you.
Yeah. So I suppose given just the trajectory of where the conversation and the session has taken us, I'll ask my second question first. So is the independent contractor model the best solution, or do we need to be looking at another model?
Well, I think, as I said in answer to a previous question, we may have moved beyond there being only one model for general practice. while we will continue to do what we can to enable and promote the partner model, which is in keeping with the way it's run since the NHS was formed in the late 40s. It may be that there is a lesser willingness on the part of some in the GP community to want to play that partner role and to seek different roles as salaried GPs or as locums, and therefore we may need to accept that there will be a broader range of models going forward, and we're open to exploring any models that we believe would deliver a good level of service at the kind of value for money that's needed.
And are you actively considering alternative models in that respect?
Well, you could say that those practices that are being run by GP federations and those practices that are being run by trusts are already different models from a GP partner. So the honest answer to that is it's already happening in some places. We're not proactively promoting alternative models, but if we were approached by someone, for example, in England, I think it's commonplace for one individual to hold a number of practice contracts and then to employ salaried GPs. And we know there may be some interest in that. We would certainly talk to people on that basis if that was if they approached us.
And focusing on the trust, where the trust have moved in, which has taken place in my own constituency and in neighbouring constituencies, where the trust have moved in, secondary care trust, I think there's a general acceptance that that's not exactly the best model. Are there exit plans in place for any of those practices to put them back on a more longer term footing around a traditional or a new type model?
So we continue to explore the possibilities. I'm going to ask Margaret to say if there's anything specific she can add as to whether any are likely to return in the near future to a different model.
Yes, so you'll be aware, Colin, we had Newton Hamilton that the Southern Trust had been holding for a period of time, and that then moved into the Federation contracting hands. And we are looking at another practice in that geographical location in the Southern Trust, hopefully working with the Federation to move that into their hands as well. So there's active engagement to move it from trust hands, who were only holding it temporary for us, into a longer term solution.
Just a quick comment, Chair, before we move on. Some of the reports back on some of those models patients were very happy with it. So hopefully the learning, whatever was making those patients happier, is able to be worked into the future models. That's me for now.
Cal, are you still looking at supplementary there?
No, sorry, Chair, so I'll come back again. So.
Okay, Colin, you're...
I think we're back now to longer term improvements, and then I'll come back in at a later point.
Again, Chair. Yeah, just in relation to the workforce, I mean, your plans to increase the workforce in the medium term, and whether or not you have a workforce strategy to deal with that.
So we have increased very substantially the number of GPs in training by 86% since 2015. This year and last year it was 121 places that were offered. We filled all of the places this year and 119 of them last year. We are doing, we recognise the importance of making sure we have the right range of skills. We don't think that we should look at this simply and purely in terms of a general practice workforce plan, but we should take a broader overview about what primary care needs. And as I've said, we're moving in relation to the expansion of the multidisciplinary teams into what I think will be a helpful space. We've engaged with the Northern Ireland General Practitioners Committee regarding 2 planned workforce surveys to include GPs working in practice and other practice staff, a full range of practice staff. So we will have, those surveys will be issued before the end of April this year. That will give us a range of data that we don't have currently about attitudes and so on.
So my question really is, and thank you very much for that response, see in terms of whole-time equivalent GPs, do we know how many we've got? Because if we don't know, then we're not going to deliver the service that we need to provide. So can you answer that, please?
We do know how many we've got. It's whether I can find that particular information in this large
But
packet.
you have that over the premise of the question is, I mean, if we don't know, I mean, then we can't plan to deliver the service and provide the service in the first place.
We do, we know that we have 1,449 GPs registered on the... Sorry? Okay, sorry, I may be going to mislead you here, Carol, I better not.
If I may, we know the number of GPs who are on the performers list. All GPs, in order to practice as a GP in GMS and the HSC, are required to be on the performers list. So that sits about 2,000 roughly. I can provide you exact figures on that because they do vary. That will also include GPs in training. So those who are with NIMD is still finalising their training to become a GP. So we know the number of people. So that's the number of people. That's not broken down to the number of sessions they would provide in practice, be it as a partner or as a locum. And that is the workforce information that we are now collecting from our GP practices in detail in this contractual year.
Right, so I'm just trying to find it.
Can I just supplement that briefly?
Yeah, go on, yeah.
Full-time equivalent GPs is what we're really looking to know. Yeah.
Yes, so we're collecting a whole range of information as the number of partners. Are you a partner? Are you salaried? Number of sessions that you deliver in your practice. That's what we're collating all at the minute, Chair.
I
No, I'm trying to get my head
don't
around
have that
it,
information at the minute. You're collecting it?
Yes, through a detailed workforce survey. We would know through previous contractual years how many partners worked in a practice, but that wasn't broken down by how many sessions, etc. they would provide. So as a consequence of the work we've done on workforce planning, we knew we had to collect more detail in regards to the actual number of sessions they're delivering in their practices. I nor the department get to set that. As I said, they're independent contractors. As partners, they can indicate how much time as a partner, be it a half-time partner or a 6-session partner. That's set at an individual practice level, and we are now obtaining that in detail.
I just think it's a wee bit strange that we don't have that information. Anyway, but it's fine.
We
When
have-
will we have it? Anyway, is the key question. When will we have?
We're sending the survey out before the end of April, so obviously when we receive it and collate the data, it'll be a snapshot in time, Chair. I think it's important to note.
Yeah.
Because tomorrow you could decide to move from 6 sessions to 3 sessions.
Yeah.
You don't need anyone's permission to do that. So we just need to be careful that what we need to know is how many sessions are being covered by GPs and does that meet the needs of our population. We don't necessarily need to know the precise level of how full-time or otherwise each individual practitioner is.
When we have that information, how often will that be monitored thereafter?
That will be part of the discussions we're having with GPC in regards to collecting that data and how frequently we collect that data in the contractual discussions.
Okay. So just again, so when will we have that information?
So we are doing a few surveys, one being the GP workforce in practices, and we're also looking at the practice team as a whole and collecting all of that information at the minute. Those surveys have to be returned to us before the end of April.
Okay.
And we'll turn those around and indeed then look at baselining, an attempt at baselining the practice teams to include the GPs.
Okay, thank you. Sorry, Cal, I just wanted
No, Chair, just because I need to just get back for some clarification in my own. So, let's look at it as a workforce model. So, a workforce model, we need to know the workforce, and then when we get the workforce, we'll develop a strategy to deliver, okay? So what you're saying is we're doing some piece of work now to attain that information, yeah?
Yes, I think it's fair.
And that's fair enough. No, I think you've given an explanation, to be fair, and whatever other figures need. My next point then is, we don't know yet then how many more GPs we need to train up. Is that fair to say that? Or we might be at that level? You don't know, you're trying to assess that at the minute.
Well, we know we have increased the number that we a need to train, and the discussion about this year's training numbers, it's always a trade-off. It's not just about what we need, it's also what we can afford. So there's always a trade-off because there'll be a desire to train more doctors, more GPs, more nurses, more social workers, and so on. There's a limited pot of money, and we have to decide where that pot of money goes.
Right, and my next question then, what are we doing to try and retain those GPs?
Well, there are a number of different schemes that we have in place, including, for example, a GP retainer scheme, which offers a flexible and supportive framework for experienced GPs who wish to continue practicing without committing to full-time hours. So this is a way of trying to retain skilled professionals who might otherwise leave the profession. That's one of the ways we do that. We have a GP mentor scheme, which is an independent, supportive and safe mechanism for individual GPs as they navigate the pressures of delivering general medical services. And that again is designed to improve GP retention. We have the Attract, Recruit, Retain scheme that Margaret mentioned earlier, and that, in addition to providing some incentives for people to join, also has elements around retention. So there are a range of different schemes that we've put in place to try to enhance retention.
No, go ahead, you want to speak?
Yeah, could I add to that? We also have implemented a GP fellowship scheme, whereby those younger GPs coming out after qualification, not all of them are FEI or trained in how to run a practice, so they would maybe lack some confidence in respect of moving from, a qualified GP straight into a partnership role. So we put in place a regional GP fellowship scheme, which is hosted in the northern, one of the northern federations, and we've also put in place a further GP fellowship scheme in the southern area, and that's to help recruit and retain GPs in that geographical area to also assist us with those practices that have handed back their contract.
Okay, and just one final question. Listen, it's not trick questions. I mean, this is an important piece of work for this committee, and we need as much information as we can, so that when we formulate our recommendations, I mean, it's a proper piece of work for us. And many MLAs have been lobbying about this all the time. So my final question is, obviously we heard from the Royal College of General Practitioners last week, and from them there's a statement from them: GPs are struggling to the point of collapse. There's an urgent need to stabilise general practice, and a key part of this is to take steps to ensure GPs remain in the profession. They warn, without action, the situation will continue to escalate and much more pressure will be placed upon an already overstretched general practice. Your views on that, do you agree with that statement, or what's your views on it?
I recognise that there are strongly held views within the GP community about the level of pressure that is on them in terms of the delivery of their services. I've tried to set out for this committee already a range of actions we've already taken, and some others that we will be looking to take in the context of the current contract negotiations that are designed to stabilise and retain, as well as then attract people into general practice. So we are working very hard to try to make sure that primary care can be successful.
Okay, thank you. Thank you, Chair.
Thank you, Cathal. David Honeyford.
Just following on from that then, the kind of the retention strategy, what steps are the department taking to support the implementation of that?
The implementation of the various schemes.
They've come out and they've said there's a retention. They've got a retention strategy. What are you doing to support them?
Well, through the schemes that I've just described to Cathal, that's the interventions that we've put in place. Some of those I think they'll all have some level of funding that attracts to them. That's the way in which we look to provide some of that. That's the specific retention schemes. And then, as I've said, we've taken a broader view, which is to listen to what the GP community tell us through their representatives, to act on, for example, the quality outcomes framework, to begin to address the indemnity issue and so on.
I think as well, if you have in mind the Royal College of GPs, their Fit for the Future report, I think a number of the key measures in that, as Peter's indicated, we've already taken action on. So I think one of their key recommendations was around implementation of the DDRB uplift. That's been done. Pressing forward with MDT, again, we've discussed that already. It's a key piece that's been done. And the other big ask was around indemnity, and we haven't gone into in detail here, but that is on the table as part of the discussions for contract. We believe we've got a very satisfactory solution to that, and that is part of. So I think a lot of what the Royal College report, obviously naturally it reflected the kind of the wider views of the service, which we've been working on, and a lot of the specific things we have already acted on or were already working on as the report was written.
Okay, so we have, there's obviously issues right across, and you've indicated a level of things that you are doing or will do in the bit. How is the effectiveness of that going to be measured?
It'll be measured by the extent and nature of the primary care service that general medical services are able to deliver. In its overall global terms, there will of course be specific sort of output measures about the number of GPs leaving the service, the number of GPs being attracted into the service, the availability of the right number of GPs to run the service at specific points and so on. So there'll be high-level quality outcome measures and output measures specifically.
So in the future we can look at that, and we will have a document or something we can say this was done, this was the outcome, or is it just throw it? Yeah.
Or is it just?
Is it just throw out all? So you've listed several things you are doing. I'm not disputing any of that, but what I'm saying is a lot of things within what we see is a lot of actions happen, but there's no check to see if there's an effectiveness to it. So that's the bit we're looking for, to see if you do something, what's the outcome from it? How's the measurement? Yeah.
Okay, so we measure. It's easier to measure the outputs than the outcomes in the model that I've just described. So we can tell you how many people took up the fellowship scheme, how many people took up the retainer scheme, how many people have been attracted using the attract, retain and refresh, retain and whatever it is scheme. So we can tell you those things because they are direct measures that flow. When it comes to you then join it all up to come to that outcome piece about is primary care doing what it needs to do, and that's an overarching piece.
And then I suppose then the amount of the numbers of retained within and the number leaving then is the other part of that, which then can be added to. Okay, well then can I go on then slightly? So what's been done to improve recruitment and retention then of GPs, particularly in the rural and deprived areas? There was an issue came up specifically around deprived areas and around rural areas. So what actions are happening to improve that?
Do you want to say some more about the scheme that you described in relation to particularly rural areas?
Yeah, so I suppose it's twofold. There is the Attract, Recruit, Retain scheme that we put in place. I'll refer to, just to pull out, so I'm looking at exact numbers, but it facilitates, I ran through a few things that it facilitates, but it facilitates a golden hello, be it an amount if you become a partner, an amount if you become a salary GP, and it also facilitates relocation costs. We have, I suppose, more individuals going through our training here from across various other countries who require now visa. So it would fund that aspect of an approved employer visa, and elements of advertising, etc. for the practice. We have reviewed that Attract, Recruit, Retain scheme. We only introduced it around January 23, so the 23-24 year, and the 24-25 year, we were taking that forward with the original specification to include all of those criteria and also outlining the funding. What we have done now is taken on board the learning, so we've evaluated that, as you've alluded to in your previous question, and we will be looking to revise that specification with a focus on an additional amount for rurality. to attract even more GPs to those areas. But, you know, the rural, I suppose, more hard to recruit areas being southern and western, we've had 13 and 8 recruited in those respective areas through that scheme alone.
Okay, and what about deprived areas? So deprived areas, there's bits of Belfast, there's bits right across there. It's the same.
I don't know if is there evidence that suggests there's a challenge in getting GPs to work in those areas?
Not overly, but the scheme is open across the region. And in the eastern, so that covers Belfast and southeastern area, we've had 16. And in the northern area, we've had 15 recruits in.
What was the targets? I'm trying to determine what success looks like or how that's measured. Is there a target in place, or is it just...
No, it wasn't a target. It's just we've offered out that funding to practices for them to avail of. And as I say, we've had 82 practices who have applied. There's a set of criteria by which the practice will apply into ourselves. So we've given approval in principle to 82 practices, and 52 of those have been able to recruit to the positions that they've advertised.
So that's 1 in 6 of all practices.
Okay, so then if we look at, so that was rural deprived, if we look at what actions are taken then to encourage GPs to remain within the whole system rather than going to private practice or south or abroad?
Well, you know, the overall package that's available to GPs through the GMS contract is the principal way in which that's done. And then, as I've said, I won't rehearse all of the additional schemes that we put in place in addition to try to retain resource. So those are the measures that we try and take.
And the fellowship scheme, which is one that encourages and provides additional leadership training, etc., for those younger GPs.
The other thing that is available, and we've sought to maintain with some challenge, is some primary care elective services, so that those GPs who want to either retain or build skills in relation to some elective procedures can continue to do that as well. So that's another way in which we look to retain.
There's no issue here at all? There's no issue at retaining, to go leaving south, going abroad, going to private?
I don't have any data available to suggest that there have been large numbers of people who've physically moved to deliver services in either Ireland or elsewhere in the world. We've talked extensively in response to previous questions that we recognise GPs are feeling under pressure in a range of different ways, and we've explained the sorts of things we've tried to do to manage that pressure. This remains, you know, an area, as I said, all of our health and social care system is under pressure. Primary care is no different, I'm afraid. And so we continually look at whether there is more and better that we can do. And we've set out some of the things that we're looking at in the context of the contract, where we're hoping that some of the measures we'll be able to take, for example, in relation to indemnity, will be acceptable, and in return we will then be able to enhance some of the access provisions that we talked about earlier.
If I can add to that, I think the headcount numbers would indicate there isn't an issue with people leaving the system entirely. We've got 23% more GPs than we had in 2014 by headcount numbers.
What percent? Sorry, I can't.
Sorry, it's a 23% increase in headcount from the 2014 numbers.
Okay.
So that doesn't.
10 years it's increased.
Over the 10 years, that doesn't indicate that people are leaving the system. We've touched on whether they're working full time, and that's what is our capacity for that. And some of the stuff we've talked about here, including the elective work, is in part to support people to have those portfolio careers. But if the question was around are people leaving to go to the south or overseas, the evidence wouldn't support that. But there's a question of do they want to work here, but are they able to give enough sessions to meet the needs of the service? That's the question.
You've just answered it. Headcount doesn't give a full picture.
No, but the question was
more
around
GPs doing less than.
But they're not leaving to go to the south, though.
Yeah, and we accept that it's, you know, a lot of GPs would say it's practically very difficult to work full time because of the demands that would place on a general practitioner. So many people are working less than full time.
So of that 23%, with an increase in number was 23%, whatever the figure was you said there. The number of sessions been delivered, what's the percentage rise or fall there?
We don't have a reliable source of data on the number of FTEs been delivered. I mean, broadly speaking, it's pretty consistent over that period of time. So, but we don't have certainly nothing to be publishable in terms of the data on sessions.
How many sessions do we have? Do we know how many sessions there are available at the minute for access for our GPs from the public? Do we know how many sessions right across Northern Ireland are available this week? Delivered, yeah.
I'm going to ask Margaret whether she would think that would GPIP provide that information?
The workforce survey will, when we get the return on it in detail.
Dr. Brent, you can understand, in terms of, you can understand concern we have here around this as to what, like, it just shocks me a wee bit that you just can't provide us the information as to the number of sessions that are covered by our GPs across Northern Ireland on a weekly basis. How do you know what the, how do you get a full picture of what's going on if you can't answer that question?
So the data that's collected through the GPIP program talks about the patient encounter. It doesn't necessarily talk about the sessions worked. So we would be able to tell you how many patient encounters there are.
Then let me rephrase that. How many patient encounters are there in a week?
So on average, it's around 200,000 patient encounters
per week. Okay, and with 23% more GPs, so that 200,000 per week, what was that figure in 2014?
It wasn't captured then. So the 200,000 figure comes from survey that started through COVID. So it's from 2020. We have the data. We haven't got.
Go from 2020 then. If it's only 2020, we've only got 5 years figures. With 5 years figures, so how many? What we're trying to establish is there a barrier?
I think when I haven't got it in front of me, but I think the trend for what's been delivered through GMS is broadly consistent over those 5 years. It's not. We don't have reliable data for the pre-COVID period. So I think there was, in the order of say between 190,000-ish, you know, when the survey first started, maybe 180,000 to the kind of current levels of around 200,000. Obviously that fluctuates. In winter, there's a higher number of contacts that we've touched on, but I mean the trend of the data is there's a consistent level of patient encounters through that.
The patient encounters is equal roughly then over the 5 years with 23% more GPs.
So we know there's been an increase in the number of GPs working less than full time.
Yeah. So
it probably broadly, it may well be that the amount of GP time available is broadly similar to that it was 5 years ago.
In terms of accountability, and again I'll come back to the nub of our committee's work, value for public money, I find it absolutely shocking. I don't know if other members are in this committee that you do not record the number of sessions that are covered. So how do you ensure value for public money if you're not measuring that? It doesn't make any sense to me. And why are we only doing this in 2025?
Because we're not measuring activity, we're measuring the outcomes and the patient encounters rather than the number of sessions.
How do we ensure value for public money on that basis in itself? That's not a proper measure.
It's a measure in terms of
demand on GP services, and if GPs aren't meeting that demand because you aren't measuring, how do we know where the gap is in terms of service delivery and demand? Are we meeting the demand? How can you measure properly if you're not measuring sessions?
So sessions in themselves won't tell you whether you're meeting demand in any case. They're merely indicating how many GPs are available for what period of time. So I think the risk is that we take this down a pathway that makes sessions more important than they have been in terms of the way in which we run the GMS contract, which is broadly the contract that's run across all of the nations and has been for the last 20 years. I'm not sure that that's taking us in the direction that's helpful, but absolutely.
Just a bit startled by the lack of data, to be honest. There's a trend emerging in relation to it, and I'm concerned that there's just not proper data collection in terms of some of the questions that are raised, and it's alarming.
The number of sessions is absolutely directly related to the outcomes that come out of the practice. Surely, or the number of appointments. If you haven't got the appointments, your people aren't getting access. It's what we're looking at. The fundamental thing we're looking at is, can our constituents get in front of a GP or be treated, whether that's in front of them or on the phone or whatever, or get access to them. So if they're in, if there aren't those slots there, or those slots aren't growing in the number to meet the demand, then the outcomes aren't there. I can't understand how that isn't.
Do you want to take that?
Yeah, I suppose, and I mentioned it before, it goes back to the understanding of the contract. The GPs are independent contractors. We fund them under a 4-country basis. Bulk of their monies would be given out under a global sum amount, and the GP practices, the partners, decide how many GPs they want to employ, how many nurses they want to employ, how many other allied health professionals they want to employ. That is the contract that was 4-country agreed, and that is why, to date, the sessions worked individually in each practice, whilst we have an overarching number of partners, because that's required on an annual basis. But the detail behind that is what we're collecting this year.
And we do collect patient data, anonymised patient data about whether patients get the treatment that they need or not, and the outcomes for that, Margaret has described earlier. So be assured that it's not that there is no oversight of what is a very substantial amount of public money going in. And that is monitored carefully, both through the data that comes through the system and also through those regular visits that are made to the practices.
I asked the BMA last week, and I'm going to ask you exactly the same question, just to get the other point. Is this if you had a blank sheet of paper and you have to dream up a system, is this the system you would put down in that bit of paper to start again?
I guess that is probably taking us into the policy space as to where it would be a political decision if people wanted to change the system that we have at the moment.
I'm not talking about political system. I'm just saying if we were starting from scratch and you had a blank bit of paper and it was to deliver primary care, is the system we have now what we would?
We know that in the 40s, when Nye Bevan was negotiating the creation of the NHS, he tried very hard to secure primary care on the same basis as secondary care, with doctors funded through the National Health System. And at that time, the BMA opposed that very strongly and wanted the partner model, and that's the basis on which we've arrived at where we've got to. I'm giving you that history. I appreciate you've asked a specific question, which I haven't answered, but I'm giving you that because it's not, there's more partners in this that need to decide what the future models look like than just government, and government has to be, in part at least, the art of the possible. So clearly, the arrangements that have existed for the last 75 years have come under a lot of strain in the last couple of years, and we have seen more contract handbacks than you would have seen during that period more normally. So that would suggest either that more funding needs to be made available through the Assembly than has been made available, or that there will need to be a broader range of arrangements. And I've set out that we are looking at broadening the arrangements, because I think the dislocation that would come from making a change to the current system and doing away with it entirely would almost certainly be greater than the benefit you could receive.
Okay, thank you. Just one more, just on e-prescribing came up last week, and we heard about the introduction of e-prescribing, to alleviate pressures of a lot of the GP's workload. It's commonplace in England, Wales, and we heard that it was described to us that easily could be implemented here. When is it going to be introduced in Northern Ireland?
So there's actually quite a complex programme of projects which go together and some of which are enabling projects that would need to be put in place in order to implement the e-pharmacy solution. We are funding the project team, and we hope that the project will start in 2027, but it will take 4 or 5 years to complete the project. So there'll be different stages and phases as different bits of the project get delivered. And that's obviously,
whenever you say the project, the actual delivery of the whole software bit, we're talking what, 8 years away?
We could be talking 7 years away,
7
certainly.
years away,
Yeah.
yeah.
again, this is quite alarming, to be honest. Like, in your letter, which, thank you, we do appreciate you providing to us for today, Premier Secretary, because it has been filled with information and is helpful and has prompted a lot of our questions today for the session, so thank you. But at the bottom of the letter, it outlines in relation to this that the Department, dependent on funding, could foresee a system in place by 2032.
Yep.
7 years, like as you've said. For a lot of people, you'd find that deeply alarming, given that technology is advancing at a rate that none of us can compete with or keep up with. So we don't be putting a system in place when actually systems that are in place today would be out of date. So why is this so slow? Surely this is costing us money by not putting this system in place. Surely this is a more efficient and effective way of doing business. And surely we should be our people should be getting the same access to that sort of a service as others. You know, it's an arduous process ordering a prescription in Northern Ireland, to be honest with you. You have to go into submit it physically in a bit of paper in a postbox, and in some cases, it's very out of date.
Yeah, it's certainly something that we would like to introduce. It has been there's been a challenge, obviously, with competing projects and priorities. So we've invested in the Encompass scheme, and that has meant that the e-pharmacy scheme has had to wait a bit longer than we would ideally have liked, because we could only afford to deliver so much in terms of IT improvement at the one time. I have had quite recently a good engagement with the project team to understand the nature of the programme, and they've explained to me, and I'm happy if it's helpful to the committee to explain in more detail. There's 3 or 4 projects that are bound up together, and it's not as simple as just introducing the e-prescriptions without having some of the enabling steps in place, and they do take some time to deliver. So I'm happy to explain that in more detail than is in this letter.
Well, most people would look at this and go, 7 years is an outrageous timeline for this. Surely this should be in place. We're lagging behind the rest of the UK in terms of electronic prescribing. There's a shelf-ready model available in other parts that could easily be used here, I'm assuming. I just don't understand. It just seems that when it comes to technology and digital transformation, Northern Ireland is just not at the races. And certainly it would seem the Department of Health are not at the races in digital transformation if we're not going to consider putting this in place 7 years from now, which clear the picture will be very, very different next year, let alone 7 years time.
I think perhaps it's worth drawing out the bigger IT transformation agenda that the Department of Health and the health system here has been on. So the introduction of the Encompass system, currently in 3 of our trusts, going live in the 2 remaining trusts at the beginning of May, is a very major investment. We are the envy of the nations of the UK. All the digital leaders were over at the end of last year. They looked at what we were doing in Encompass, the fact we have a single imaging system, the fact we have a single laboratory results system, and they all said that you are well ahead of where we would, and that's where we would like to be. We are the only system that I know of that has introduced an electronic patient record system for both health and social care. So I think the comments more widely about Department of Health not being at the races in relation to IT aren't correct. I accept this is a project that has had to be delayed because of the investment that's been made in other projects. There are always choices to be made, and I can absolutely understand why others might take a different view as to which project should be prioritised. But I'm just explaining how we got to where we got to.
Just in terms of, because we're talking about the GP services after all, your letter very kindly confirms that GPs will only have a limited read-only view of hospital records. Why were GPs not given full access to patient records and Encompass from the outset? And surely that's an issue. And what timeline and funding are in place to fully integrate GP records into Encompass?
So the scale, as I said, and nature of the Encompass implementation is massive, and its extent, in fact, it covered social care as well, meant that we had to draw lines around what is and was not achievable. So the model put in place for GPs with the access only is in an ideal world, of course, we would have a fully integrated system covering all areas and also covering the independent sector too, because there is an interface there with secondary care. Those are things that need to be considered as future phases to the Encompass programme. But our focus, I think correctly, has been on securing the proper rollout of what we have committed to, and we'll then seek to optimise the use of the system, because otherwise you'll have a great system, but you're not using it fully, and it will have very substantial amounts of really important data that will help us to manage and run our system better. And we will then look at how we can extend it to other fields, such as primary care, where in an ideal world, yes, we would be looking to do that. But there's a limit to how much can be taken on board at any one time. And I think my judgment is that we've sized this appropriately, and by providing the access, we have at least mitigated the worst of the risks.
Okay, and you've sort of answered this, but in terms of adding on as we go along, out of hours, we've referenced it in your letter as well, and it says the GP out of hours remains on the legacy system. So why is the GP out of hours still using an outdated IT system when we, when it's the same answer, I suppose. Is this something to be looked at a later stage?
Yes.
And if so, when? So in relation to the 3 points that I've made, when could we see this dealt with under Encompass, all taken under the one system?
So we're still, I don't have a timeline that I can give you today in relation to that. We don't have a fully fledged project plan for future phases. There is work that would need to be done both on affordability and viability of delivery. So we're some way away from being able to achieve that.
Cal, are you looking at?
Oh, sorry, Chair, it's passed now.
Okay.
Thank you.
Colin, Gilder?
Thanks, Chair. And I suppose I want to start off by going back to that 200k sessions figure, which was mentioned by GPs and mentioned to you. So that's worrying in the sense that it's 1 in 10 of the population seeing the GP effectively every week. Do we know how many of those sessions the GP was the best person to see?
I think there's no way of measuring that now. There's 200,000 interventions with primary care, so it's GPs plus all of the other health professionals who work in GP surgeries. It's not just GP contacts.
Okay, so in general, I have to say I am concerned at the amount of times during this session we've heard we don't have that data. I mean, data has never been easier collected, and maybe more importantly, easier analysed. There are lots of, so I do think we're behind the curve in that sense. The reason that I'm asking that is my question's around MDTs, and I'm wondering how we create an MDT model that's appropriate unless we have the data to know which professional is best to see. So, and I understand that before I came in that you had announced a kind of a welcome increase in the expansion of the MDT teams. But what's your assessment been of the MDT rollout to date in terms of its effectiveness in supporting primary care more generally for the population as well as for GPs?
So we've undertaken, we're well advanced in terms of an evaluation of the MDT scheme to date. And what that shows is the number of patient interactions for the main areas, which have been mental health, social care, and orthopedic or physio related matters. The evaluation, we hope, will be published in due course. And hopefully in the coming months, actually, weeks and months. The evidence suggests that there's been a 12% reduction in the number of referrals to core trust services for those MDT practices compared to non-MDT practices. And it suggests, for example, for adult mental health services, that there's a 32% reduction in referrals. Now, the 12% is a global figure, so the 32% needs to be read in that context. So I think it's 300,000 patients were seen by MDTs in 23-24, and of those, there was an average of 7.5% referral to secondary care. So hopefully that gives you some of the data and evidence. As I said, there is an evaluation that is not complete but is nearly complete, and we hope to be able to publish that in due course so everybody can see that data.
Okay, and I should declare the interest, as previously having been a social worker myself, but the Audit Office report indicates that nursing and social work will be reduced in new MDTs going forward. So is the department still confident that they'll reduce pressures in a similar way to what you're outlining on reducing the pressure in secondary care and still represent value for money? Or can you give us some understanding as to why those professions will be reduced in the new MDTs?
So there's a number of things. The first is, with any new model, you need to learn from the model and what works and adjust accordingly. We're also very mindful, as you will be, that social workers, there's a pressure in terms of the availability of social workers in secondary care as well, and it's important, therefore, the model actually had more social work attached to an MDT than it did other professions, and we're looking to perhaps make it more similar in terms of its approach. I think we also need to recognise that MDTs can't purely be or shouldn't purely be a medical model. So they should have a connection here to the voluntary and community sector for services that can be delivered in that way, because that's a better use of our overall resources. So we will look to continue to develop the MDT model, and some of this is about taking account of wider system needs. Some of it is also then about what works and how we can make it most effective.
Okay, thank you. So I'll note there seems to be a bit of a mismatch between the percentage of population covered. We're looking at 8% currently, as opposed to the third that you're reflecting.
So 8% get the full MDT service, a third get some of an MDT service.
So the additional money coming out of the programme for government will increase to 2/3. Does that mean that will double from 8% to 16% for full?
2/3 is 66%.
Yeah. So, but will the increase? So, what amount of the population will go from 8% currently full MDT?
The extra,
what percent will be in the new model?
The extra investment will enable the third who gets some service to have a full service rolled out, and then for that service to be rolled out for another third of the population as well.
Okay.
Does that make sense? Sorry, am I?
No.
Okay.
Not to me.
Apologies. Let me try again. In that case.
But honestly, no.
So the plan here is that, broadly speaking, 65% of the population will have access to a full MDT service in 5 years' time. Okay. If that makes sense.
And what's the equivalent figure now currently? So it's
8%. 8% has access to a full MDT service, and a third has access to some MDT service.
So it's going to go from 8% currently to 65%.
Yes.
Okay. I welcome that.
And 35% part MDT. What's the rest?
So there won't be part of the population that has part, because that 35% will be getting the full service along with another 30%.
I'm confused now. So,
don't.
So is there
class in here.
Is there 35% don't get any of this?
Yeah.
There'll still be a third of the population that is not receiving an MDT service at all at the end of this, and there will be a need for a further phase of rollout to do that.
Yeah, that's understandable.
Yeah.
Thank you.
We're doing an inquiry.
Yeah, it's just, it all comes back to me for how many full-time equivalent GPs do you need to fill the service levels required? I just don't understand how that question can't be answered.
That's the question. I just because I've been waiting.
Is that the question?
No. That because there's 23% extra.
Yeah.
There's a number of reasons now we understand, and we're trying to find out as to why we can't access GPs. So work-life balance and everything else, change of hours, working out. And we need a better understanding of that there. That's where we're at. So unless we know what the workforce is, we'll never be able to deliver the full programme. That's all we're saying. So the more information we can get in terms of figures and stats, that's
Okay,
basically what we're-
let us see if we
So,
can provide any
yeah,
further
absolutely.
information to help the
And I appreciate
committee
the
in
number, the
regards to
increase
that.
in numbers, you've explained all that. I'm just trying to get my head around all
But,
of that.
but we also had a question earlier, you heard about demand.
No, no,
And what happens with, and so this is not a, that there's multiple factors here that determine whether you can meet the full range of needs or not.
100%, and we're doing an investigation there and inquiry into GP practice access, and the more information we have, you know, then we'll be able to formulate our recommendations. That's the point. And there were some answers already I have had sound, but that's my point.
Yeah, we're just trying to establish that 23% of an increase in GPs doesn't necessarily mean a 23% increase in service level.
And
That's-
we're not suggesting there is,
No,
we're
saying that either.
we're saying that broadly we think the service level is roughly the same as it was previously.
Yes,
in
exactly.
real
That
terms,
makes
it's
up that percentage.
In real terms, it's a reduction with more GPs.
It's not. No, it's not.
In real terms,
More
it's a,
GPs and less service being delivered. That's what that means, isn't it?
I think the number of sessions being worked by GPs is lower than would have been the case previously, but I think we're saying that the level of service being provided is consistent. The point was, are people leaving this system to work elsewhere? I think the numbers don't support that, but there is a question of those who are here, the extent to which they're working what you would call full-time, or the extent to which they're working a portfolio career or less than full-time.
Well, am I right in saying that you can't answer the question of the number, just to be clear, because I can't, the number of full-time equivalent GPs, you don't know right now how many you require to service the level of need out there, right now? Full-time equivalents.
So I don't think there is. I think the point is that there isn't one number as to because the model, the introduction of the MDT model will change the demand on GP on general practitioners. So you've got to see this in a slightly different frame, I think, than
I understand. Yeah.
In the traditional sense?
No, I understand that.
you're just looking at this purely through doctors.
Yes, I get that.
And we've
that's
got to
part
look at
of
it
it,
through
exactly.
the overall primary care
Yeah,
provision.
okay.
Could I maybe add to that? We have done modelling in regards to the number of GPs that we need now, which is fed into, you know, the number of training places, etc., and what we may need in the future. But as Peter has said, we need to look at that in the context of the whole practice and what other allied health professionals are bringing to the practice, because that will have an impact. Be it up or down, but it will have an impact on the number of GPs that we ultimately require. But we have done modelling.
I asked us, Chair, how many GPs are in training at this moment in time?
475.
475.
And just my final point before I come to Colin, who's waiting patiently online. What will be done to improve services for the third with no MDT for the next 5 to 10 years? That section of the population will be left with no access to that service?
That's correct. There will be an inequality for that period, and we would very much hope that we will be able to move to rectify that inequality as quickly as possible, as soon as the funding becomes available. And as I said, there is an actual people resourcing issue as well that needs to be taken into account.
I think we're currently developing plans for implementation of MDT. We're looking at that as implementation across everywhere. The first 4 years of that we've got funding secured for, and that's where the attention is going to be. But we are looking to plan for the completion beyond that. And so, so for practice in an area that isn't getting MDT, they will see where they are in the queue, and it won't be in the immediate 4 years, but there will be a plan in place for when that will be addressed.
Yeah, but that won't satisfy the population that's missing out on this service, really.
If I may add,
And it really comes back to this question of equity of service. Is people going to be left behind?
whilst it be longer, absolutely, for those areas in respect to the MDT, what we have done in the meantime, and even currently in advance of the next phase of the rollout of MDTs is offer those areas opportunities around advanced nurse practitioners, and that was in some way going towards helping that inequity in the intervening period. So we've invested 3 million in advanced nurse practitioners across the region. We have about 34.8 full-time equivalents in place. So those areas were specifically for that additional staff outside of the MDT.
Will you match the rollout of the MDTs with the pressures that currently exist and where the most pressure is in terms of GP profiling?
There is already a
Yeah.
programme set out
Yeah.
of areas.
So
that
Minister Swan in 2022 announced the kind of the rollout sequence for the rating areas. That sequence was developed based on a number of factors, one of which was deprivation and need in the area. So that featured into that plan has been announced. At local level, so as we go forward, it'll be at each trust level in partnership with the federations where they develop their detailed plans as to which practices will get which staff and in what sequence. So we'd expect then that local knowledge will inform implementation at local level.
I think it's I think it's important as well, just to highlight the investment that we've made for all practice in regards to practice-based pharmacists, which again is in addition to multidisciplinary teams. So that's 20 million of investment that has went into general practice to help our GPs manage medication reviews, medications, which we all know are a high-risk area in respect of general practice. So it'd be remiss of me not to highlight that significant investment.
Okay, Cal, briefly, and I'll let Colin in.
Certainly, Chair, and thanks very much. Just briefly, Mark, you said earlier on that the number of locums was 300 plus ish, and then now the 2,000, so it's roughly 15% plus. So,
well, the 2,000 will include those doctors in training in their final year as well.
Well, then send us 10% price. My question is then we should be trying to incentivise salary GPs and get them in the system, because part of the question we were asking earlier on was about incentivisation, and it could be read that locums are incentivised taking it. So that's something we need to maybe get the figures on as well, if you have any of that in terms of exactly what that is for us. Yeah.
I think we do have the numbers of salaried GPs and we can provide those.
Yeah. Thank you.
I think it's 314 currently down as salaried. That's up from 117, I think, in the past couple of years.
Okay, because in the short to medium term, we're going to address that. I mean, I know all the people's asking about MDTs and everything else, but we're going to have these problems for a period of time. Thank you. Thanks, Chair.
Colin Crawford is joining us, Permanent Secretary, remotely. Okay, Colin, can you hear us and see us okay?
Yeah, thanks, Chair. And can I thank the panel for both their time and for their answers this afternoon. And apologies, I'm not there in person for your presentation. Just in terms of longer term improvements and also a question on investment in general practice, the Chair picked up on it earlier. Per capita investment in general practice is lower in Northern Ireland than elsewhere in the UK. As a committee, we've heard some concerns that it's also significantly below what is needed to provide safe and effective services. Given that early intervention is widely recognised as the most cost-effective way to treat patients, why is this?
Okay, so as I said, I think in answer to a question earlier, the percentage does depend on the base that you take it from. I'd make a number of points. The first is if the overall budget, taking a percentage is only a proxy measure because it depends on whether the overall budget is adequate or not, because you're taking a percentage of what the total is. Secondly, the data in the Audit Office report took a percentage of the overall health and social care spend. I think if you were to take the health-only spend, in other words, take social care out, then the percentage would go up. It would go up to 6.4% based on the Audit Office data. So I would just highlight those features. I think our numbers are broadly similar to those in Wales, but they are less than England. So that's, I think, the position that we're in terms of funding. So, I mean, in terms of why, I mean, I think that as I've explained, this has been, there's been quite substantial increases in recent years in a number of different ways to the primary care budget and to GMS in particular, and we've rehearsed a whole range of different steps that have been taken to increase that. We are constrained. We're constrained by the pressures that exist on our system more widely, and we absolutely agree that early intervention and prevention is the key. So the total of 60 million of investment in the next 4 years in MDTs is squarely in that space and will make a substantive difference in relation to that particular area, because that's all about intervening before people need interventions from either primary care doctors or from secondary care referrals. I think that is the direction of travel, and our minister, as you will have heard, is very committed to the kind of shift left approach, to move to more community-based interventions, to more early intervention and prevention, and to a greater public health agenda, which joins up not just the work of health, but the work of health with many other government departments as well, which I think is common ground and widely agreed across all parties.
Okay, in England it is 10% per capita. Do you know what it is in England?
I'm sorry, I think maybe something got lost in translation there, but I'm not aware of a 10% figure, and I don't know where that's come from. But if you can give me access to that data, of course, I'll have a look at it.
At a previous evidence session, we were told that the investment in GP services in England is 10% of the overall budget, and there's a campaign to increase that to 15% given the level of demand on services. We're not sure of the figure in Scotland, which is what Colin was asking. I don't know if you have any indication as to where it is there.
So there are difficulties comparing data. Our understanding is that England is at about 8.4%, not 10%. But if you have a data source that we can look at, I can certainly try and see if we can do what we can do by way of comparative data. Not all of these things measure the same things, I'm afraid. That's the reality, and it can therefore we can end up imagining that the situation is rather different than it actually is.
Colin?
That's great, Chair. Just one more, if of time, to the panel. It's nearly 10 years since the department published the Delivering Together. The commitment in this was to enhance support in primary care. Do the findings of the Audit Office report demonstrate that the department has failed or at least struggled to implement Bengoa?
Potentially taking us a good bit beyond just the narrow confines of this report, I think. But it does raise an important point where a lot of people have associated the Bengoa report purely with being about the reconfiguration of hospital services, and it is much wider than that. It is absolutely about how we develop and build better community-based services, whether that be through primary care or other means. So it is true that a succession of major challenges such as a pandemic and a financial austerity have created real challenges in terms of delivery. But I think through things like the multidisciplinary teams and the fact we are now able to make some further progress, that is the kind of thing that was absolutely what Bengoa was talking about. So we are slower than we would like to be, but we are getting there.
I would say, you know, the year that Bengoa was published, it was 9 years ago. You know, slow is an understatement that many would say, to be honest, in terms of implementation.
I think, though, it is right to recognise that for 5 of those years, there was no ministerial leadership in the Department of Health.
Yeah.
That for 2 of those years, there was an unprecedented global pandemic. And I think if one glosses over those things and imagines that they didn't happen, that's a mistake.
Believe me, Secretary, I'm certainly not glossing over the absence of these institutions or the impact it's had on services for our people or in people's lives, and I've no doubt that you aren't either. Just a number of
Sorry,
questions.
Chair, if I can, just on that point, have we slightly overlooked the potential benefits in primary care, and transformation has become too much about the hospital sector? You know, you talked about social prescribing and all of the potential benefit there. Do we need to refocus a bit in that respect?
I think that there is absolutely a need for a different understanding of what health transformation means, a much more broadly based transformation which brings in the public health agenda, that whole community focus. It recognises that the likes of our digital transformation and our workforce transformation are core parts of our transformation. It's not simply about secondary care and the location of services. So thank you for raising that.
You think our current system is proactive enough, or is it too reactive? Are we reacting too much to the circumstances we're presented with instead of planning ahead and saving money in the interest of the taxpayer?
Would you like to give a little more context around that question?
Yes, well, for instance, you know, GPs who have presented to us last week are telling us on a daily basis of the pressure that they're under, their services are under. The public that we represent are telling us that they can't get access to those GPs. GPs are saying that they're not properly resourced to meet the demand out there. They are asking, from my understanding, 1% of an investment incrementally, investment in services. Would it not be better, and certainly in the interest of public money in the long term, to invest now to save later in terms of supporting those services? Because the sticking plaster approaches, which are all over this, in terms of contracts being handed back, taking over practices, locums being placed, is costing and will cost more money in the long run. Is an investment now not the better solution? And listening to our GPs and responding to the concerns of our public, is that not the solution?
I think I'm going to repeat myself. I apologise, Chair, but I've highlighted all of the different areas in our health and social care system where there's a strong case for additional investment. And I've highlighted the fact that as things stand, the Assembly has not chosen to decide that the Department of Health needs the money that would enable it to make those investments. There are efficiencies that can be made within our system, and it's absolutely right that we should look to make sure we're making the best use of the resources we have. And this year we will have made over 200 million of efficiencies, which is unprecedented. And we will be putting additional pressure on next year for further efficiencies. But there is ultimately decisions to be taken about prioritisation, and general practice is one of a number of extremely strong cases for additional investment.
Yes, I'm very aware of the pressures overall. My concern is that the situation that we are in, from the evidence we've received from those at the cold face, is that things are going to get worse. In fact, the 1% investment was simply to stand still, to keep the lights on, is what we were told at a previous evidence session. That is extremely worrying, which shows that things are going to get worse. One of the witnesses before us, Permanent Secretary, told us the GPs, they used the word extinction, actually, in a phrase. Now, that might sound a bit drastic, but maybe that is how GPs feel. The reality that I see here is that the department, in my opinion, are not taking the concerns of GPs seriously and are not responding to the concerns of the public who are affected as a result directly. And I appreciate that this is a policy matter to an extent in terms of the increased investment, but the role of officials within a department is to guide the minister and to place the minister in the best possible situation to make those decisions. And it is my view, 10% in England is the figures that we have here. Regardless if it's 10% or the 8.4% that you've said, the investment in GP services in England is higher than it is here. And our GPs are very conscious of that. I'm very worried we're going to have a situation in the year ahead, or in the next few years, where all of those things we've discussed today are going to worsen. And it's going to cost us more because we are not dealing with it now. That's the concern we have. And I don't believe, given what I've heard today in this evidence session, that you have the data before you to properly deal with this issue and analyse it effectively to find a solution to it. That sounds critical, I know, but that's what I'm picking up from today's session.
I've heard what you said. I don't think you asked me a question, so I'm not planning to respond.
Okay, I've made my point. Anyone else? Okay. Members, thanks very much. Permanent Secretary, I want to thank you and your colleagues for being with us. We do appreciate your time. You've been with us for quite a number of hours, taking a significant number of questions from us. I have to say that this is a very important issue for our public, and I'm sure you're very conscious of that. We all, at some point, will require the help and assistance of GPs, and it is vital that we have access to them. Just before I do allow you to leave, and we thank you for your patience, is the CNAG any comments to add? No? Stuart? Okay, members are content? Thank you for being with us and for taking our questions, and we do hope that the department will furnish us with the extra information that we require to satisfy this inquiry. Thank you. Okay, members, we'll now move into closed session. Thank you.
Senate Chamber. Sound. Senate Chamber. Sound.